Here to present the rapporteur's report of yesterday, day one. Day one, it all began with the vada, idli, and upma for the breakfast. We all had it, and then we came for the registration, where Mrs. Rekha helped us, and then followed by forming the groups. Dr. Jyoti helped us, a hassle-free group making. And we all have different colors, right? So colorful groups. And then, the most important thing, the ground rules. Ground rules were laid by Dr. Jyoti. But then, actually we say that rules are to break. But then the groups are so good that no rules were broken yesterday, except for in between, dosing in between. That was not in the ground rules. Okay. And the morning we had introduction session by Dr. Padma, which was really interesting, where she added the ice breaking with that. So some questions were given to each participant along with their introduction. So the questions were so interesting, and some were crazy, where we saw people wanted to go to Russia, and some becoming ghosts and aliens. And finally, the ice breaking was really cool by dance with one of our participants. Then we had inauguration, where the observer was there. She impressed on the scientific basis of medical education, right? So we just don't think there is so much behind medical education, but she impressed us with that. And the inauguration was graced by our Dean, Associate Dean, and Kailash sir, and and also the NMC observer. And first session on CBME, where Dr. Padma ma'am, she told us about the paradigm of CBME paradigm, and there we learned many definitions, right? So competence, goal, role, and we were also made a group activity to write the differences between the traditional teaching and the CBME teaching, right? And all the groups made it they picked up very well the differences. The outstanding difference says that CBME curriculum is outcome-based, student-centered, whereas the traditional teaching was also had the hidden curriculum, but it was not structured as that of the CBME, and newer things were added in the CBME, like structured assessment and several things. And then followed by tea break. Then we had the second session by Kailash sir, where he told us in detail about the regulations of graduate medical education, starting way from 2019, where it all started. And then there were two revisions in between, in 2022-23, and the newer one which we are following now is 2024 regulations. So the newer regulation, the foundation course is made to 1 week, and then in final year, part 3, in 22-23, they made a change where the ENT and Ophthal were in the part in the previous year, but then again they revised it in 2024 to be in part 3 of final year. And then sir also told us about attendance. Theory should be 75% and practicals should be 80%, and the assessment is 40% theory, 40% practicals, and aggregate should be 50%. And I was like, Kailash sir can even tell all the regulations from 2019 to 2024, even without a PPT or anything. And then the sir also told about aligning and integrating the, this is the next session, the longest session by our Associate Dean and Kishore sir sharing the session where they talked about alignment and integration. So we all know sharing, nesting and correlation, right? So ma'am made us all to step up the ladder, right? You remember the ladder with all the 11 steps, and we all stepped till the 7th step, and we can even go ahead up to the 11th. So, and 20% integration is a must. And then Kishore sir gave us an example of anemia where we did a group activity. Yeah, before that, sir made us all to stand up and do the group activity where right was made left and left was made right. And then before the lunch break, ma'am came again to make us all to earn our lunch, right? You remember? We all earned our lunch by doing the group activity, and we all did that. We had a good lunch, and after that, post-lunch, though was difficult, Dr. Padma Sudhakar sir, he made it interesting by talking on Atcom module, where he impressed over the basic principles of ethics and also the Kalamazoo communication skills. And then followed by Dr. Deepthi and Dr. Siddharth on electives. So that was very relevant to us because we finished the block 1 electives recently, and we are still doing the block 2 electives. So, and there was a group activity which was really interesting, where we picked up the new electives which can be done. So the podiatrics thing and the trauma care and stress test, all these things are the really new electives where we can implement them. And the last session, again by Dr. Padma, who started the day, she talked on ECE, early clinical exposure. So that was also interesting, right? Our photographer was made to come, and we were asked to write the observation. Neither he knew nor we knew what was happening. And that was like the first year student when he goes to the elective, early clinical exposure. So based on that, right, so we should make proper planning activity and distribution where 30 minutes of introduction, 1.5 hour the hospital visit, and then followed by 30 minutes sharing and 30 minutes reflection. So that would, if we frame the proper guidelines, the ECE would be really beneficial and good for the student. And ECE is also assessed by taking the evaluation feedback forms. Finally, we ended with a post-test. So I forgot, in the beginning we had a pre-test, and then, sorry, we didn't do the post-test. Yeah, sorry. So today we will do the post-test, yeah. And beginning yesterday, we started with the post-test. So pre-test, sorry, pre-test, okay. And we all enjoyed the sessions yesterday. All the sessions, from every session, we learned many things. Thank you all.
Thank you, ma'am. Moving on to the day 2 sessions, I would like to invite Dr. M.S. Sridhar sir, Professor of General Medicine, to take his session on Atcom module. I'm sorry, student-doctor relationship.
Namaste. Gurubhyo namaha, sarvebhyo namaha.
Hello.
Today's discussion is student-doctor learning method. Student-doctor ఐటీ వాళ్ళ దగ్గర ఉంది కదా, అన్నీ ఉండాలి కదా. అది ఉంటే తెప్పించండి, పర్వాలేదు, ఇంకా టైం ఉందిగా, తెప్పించండి, మేము వేరే వాళ్ళకన్నా పనికొస్తాయి. Yesterday, during ice breaking, Dr. Padmavati gave slips to all, but she forgot to get response from all. I do not know why. The slip is with me. Because that's a very important thing. What we teach, what we do, finally it should come to a conclusion also. So it's still pending. Let me complete it first. It says, what's the biggest risk you have ever taken and was it worth it? Very good question I got. That's why I wanted to answer it. Talking before you is a great risk. Talking in a group is a great risk. Teaching students is a risk. Facing teacher is a risk. Talking to the administrator is a risk. And all this we have to teach the student. Before we go to that, it's all relevant to that. Let me tell you, everything under the sun has already been told. There is nothing new. We are only rephrasing it. We are only reorienting, rephrasing and relearning, unlearning. All these things are happening. Now, what is the risk in all this? Speaking the truth. Speaking to the authority. What Greek people used to call parousia. That is, speaking to the authority. Teacher is the authority. Doctor is the authority. Patient cannot talk to the doctor. Student cannot talk to the doctor. Think of your own training. How often you spoke with your teachers? Leave alone certain institutes where they foster talking with the teacher. Most of the place, it is a superior, subordinate. That is how things happen. Suddenly we say student-doctor learning method, where student is in a position where he can think he is at the same level as the teacher. Though in knowledge he may be inexperienced. Still, that is the thing which you have to foster, which is a very difficult one. Sir, I am in a meeting, sir. Here, academic, this one CISP. Now, we talk about competency-based education, new framework, new curriculum and all. Now, what is the fun of learning all these things? Gnanena, karmana, sikshaya, cha hinaha, gnani nasyat, kevalam pataka saha. That means the one who has got knowledge, siksha, that is teaching, action, all these things, if they are not there, is as good as just a reader reading from the book. In fact, we always say we deliver a lecture. We say deliver a lecture. In Russian, they say reading a lecture. Reading a lecture. Right, sir? Yeah, 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 yeah. What do they say? Yeah, Chitayu lecture. That's, I read a lecture. It's not like that. You are transmitting knowledge. You are transmitting knowledge in a way that they can implement. And when they are going to implement 5 years later, 10 years later, 4.5 years, 1 year, then 3 years, then 3 years, then they start implementing. If people aim for super speciality. On the other hand, whatever little you learn, if you start using it from the beginning, that will be good. We start with an activity. Where is Dr. Lokesh?
Sir.
Please give an activity for the group. A group activity. You have got 5 minutes time. He will tell.
Sir.
And then you write down on that.
Sir wants to tell about your experiences. What are your experiences during your undergraduate time? Not after becoming graduates. What are the experiences about your learning, and how did you learn from your teachers? How did your teachers taught you in your undergraduate training? You can summarize it group wise and present it.
Now,
After 5 minutes.
let me clarify. Whether you had an experience of being a doctor as a student. For example, sometimes fortuitous, when I was a first year medical student, there was a exhibition in Tirupati, exhibition ground. A stall was there for medical stall where a doctor has to sit. No doctor was sent, I was sent. I was a first year student. I was sent to be there from evening 6 to 9 o'clock. I didn't know anything, and I went and sat there for 15 days. So that 15 days, I acted as a doctor. That means I'm forced to learn certain things. So each one of you would have had some experience where you saw the glimpses of practicing doctor, which you are doing now. This you did as a student, either on your own initiative, or on the initiative of your teacher, or on the initiative of your senior. That experience, quickly brainstorm for 5 minutes. As you brainstorm, you write it down. Somebody be there, as they're telling, you write down and quickly present to the plenary. Then we go ahead with this, please. The time starts now.
Excuse me, sir. Sir, can you share the experience of intern, sir?
No,
Internship.
only student.
No, sir. Only student, sir.
Only student. First to 9th semester. Because we're talking about the student doctor.
Summarize చేసి రాసే. నువ్వే రాయాలి. There are graduates from the abroad also. So even we want.
During studentship. See, even if you studied on Moon or Mars, it doesn't matter. Cross-cultural experience.
Just once and we did CPR. Me and my friend, not only me. One patient went to toilet. That patient fell. CV collapse. So only me and my friend. We have them. No system, no nothing there. Before just we used to do we were only 3 back fresh college hours. Only supervisor, there was they were doing just for see how these they didn't give both of them. Ammo was revived. Suddenly we called one of the friends called for and me and my other friends were doing. They called for them, they brought them, they came over this and like attendance difference. I don't remember exactly. But one joke stated what happened. That is the surgery. We went for surgery, rotation. One of our surgeon was there. What he did in terror surgery, he took that bottom swabs, kept on that swabs, he kept on there on surgery, that around that position. When he kept pottery on that, it got fired. Bedsheet. Second phase. So it got fire. Then again what he did, you know, he took that cup again, spirit was there. He put it to water again, for that it got fire. That I took the what it towel, me and other look at me, what extinguished that intention. Reality actually. The patient just got 1 second, like how it will become a gas, not a gas pipe, like directly from fire. Spirit is there. So it got
5 minutes. As we are going through the activity, just go through the slides also. Slides which are given by NMC, go through that.
The first question. Because only supervisors were there, we used to see them.
Yes, you can start presenting. We start with, you are completed? Then, okay. Which group? Number? Blue. This is a blue group. Okay. We start with the blue group.
Good morning, sir. The points that we have noted from discussing in our group are, we used to experience the clinical postings, whatever our seniors have experienced, and we used to look at the lens of the seniors. So we used to follow them. And we used to have immense respect for the professors. And there used to be less interaction with the professors as well. And a lot of learning used to be self-learning because we used to read standard textbooks from the library, and there were not online resources available at that time. And we also used to have extra clinics in the evenings by the postgraduates as well as professors. And sir, when you asked me, did I feel like a doctor when I was a student, I never felt so. Because I always felt that I'm looking at a pathology or a disease rather than a patient himself. I think we should incorporate that feeling into the students now, that we should look at each and every patient as a human first, then as someone having the pathology. And one experience that I had was my pediatric professor named Dr. Manohar used to tell me, the patients are ignorant, so look at each and every patient with so empathy. That's when I think for the first time I felt that I'm a doctor and I'm treating someone with a disease. Thank you, sir.
Thank you. There are a few observations and corrections also. Here, nowhere there is an activity as a doctor. It's an experience from seniors. That means it must be observation. Less interaction with professors. So there is so much of social and psychological distance. Self-learning, it has nothing to do with it. Extra claims, nothing to do with it. But one thing which he said, and which he ought to correct is, patients are ignorant. No, patients are not ignorant. To think that patients are ignorant is our ignorance. Patient knows what he wants. So never underestimate a patient. He may be illiterate, he might not have gone to the school, or he might not understand medicine, but he is as wise as anyone of his age, or more than that. Please don't use the word ignorant for any patient.
Sir, I mean in terms of only medical science, sir, not
No, even
general.
medical science we cannot say, because sometimes, quite often we learn from patients. Quite often we learn from patients. Next group, which group is ready? This group, which is this group? Red. What do you want to say?
So during my ophthalmology posting, my professor Dr. Ramakrishna sir asked me to act like an optometrist for half a day, sir. So I was then checking the eye power of many patients. That was the first time that I felt like a doctor. So many patients were thanking me. They were showing their gratitude. That was my experience.
Anybody, anything else? Guided one of the family members.
During my first year of MBBS, my sister had undergone appendicectomy, sir, which I don't know regarding about that. So I learned about it and I asked my seniors. Then I have guided my family whether it's safe to do or not.
So guided the family based on a context of illness in the family. The last one, what is that? Cooperative. What is it? Competitive. What is it? Competitive.
During my first year, I had very less interaction with the patients. So like we weren't exposed. We didn't have the early clinical exposure. So I was more competitive. I was more into theory. But as years went by, as we had more patient exposure, my perspective changed entirely. So I concentrated more on the clinicals, more on the examination part than the theory.
Nice. Here, at least there is one experience of acting as a medical person, doing some refraction and all. Though it was a fragmentary, though it was a sort of reinforcing or some self-fulfilling activity at that time. Very good. That's also good. And these two people, they have shared certain things. And let us see, yellow.
This is a collective opinion about what we felt during MBBS. First of all, we were never made to feel like a doctor. And there were a lot of toxic teachers targeting students, which I had personal experience as well. And if anything was related to studying, usually we sought the information from seniors. And there were misguiding seniors as well. And then some faculty used to take classes, but very irregular and a very short period of time. So there was no proper guidance. And hostel life was better than the hospital life. Made to feel embarrassed in front of the patients, because patients, obviously they tell one thing to us and the other thing to the examiner. Embarrassed in front of the patients.
As I already told you, it is one of the relationship between the teacher and the taught is one of inequality. So, as I already told you, doctor and patient is also inequality. That's what we are trying to bridge. Authoritative and submissive. So we are talking about democratic, where you are at the same level so that you can express. This democratic or expressiveness, these are all more of Western concept. The Eastern concept or Oriental concept is that the teacher knows and we have to obey and learn. By obedience we have to learn. Ultimately everybody learns, and how you learn, that is the thing. And I don't think these are all wrong. These are all a different paradigm of learning. Very good, nice. But the one thing is, here again, the first thing he wrote is, never made to feel like a doctor. So that is where we have to think of student doctor. And here also he said afraid of professors and less interaction with professors. That's what he has also written. Let us see what this green group has to say.
When I first joined in my the third year, the general medicine staff, I don't remember his name, but I remember what he has made me to write in my book. He told me to write, patients are always correct unless proved otherwise. He made me to write on my first page. My medicine professor, sir.
Medicine professor made you write, patients are always correct
unless proved otherwise.
Okay, good.
And I want to share my pediatric ICU experience. There's a little girl who got Japanese encephalitis.
That was when you were a student?
Yes, sir.
Okay.
She got admitted with Japanese encephalitis. She was in ICU, and we used to take cases there. So that time after, the mother, we got connected to mother, and she used to ask her what this will be the prognosis. Even though we don't know, we used to assure her, no, everything will be fine, everything will be all right.
So that's one thing. So everything will be fine. There was an article in 1967 in New England Journal where a patient writes about hemiplegic. He says the patient doesn't want to be told that everything will be all right if it is not going to be so. And he wants to know with honesty what are the methods available and how far they have been tested. So that's a very important thing. So these things we have to impart in student doctor. This one. Now,
sir,
law. Please continue.
My experience. First, I will tell the surgeon experience, sir. What I felt during my, I think, third phase, when went for second round postings. There was a very good surgeon. He used to teach a lot. So nice. But once when he was about to communicate with the patients, especially during rectal examination and whatever examinations he used to do under private space. We were students. Actually, what he used to do is he used to pull the trousers very fast. Every trousers, and he used to hit the patients because very poor patients. It's like outskirt. It was Raichur. So there are all laborers and all. He thought they will not oppose anything. That too, it was around 10 years back itself. But still, that was quite embarrassing. Everyone was laughing, but I was not laughing for that. But that is a very embarrassing thing. And one more experience last I want to share is, me and my friends did CPR when we were not doing anything actually. That was in first postings, second phase. Surgery postings, one patient fell in toilet. So because of hypovolemia, anemic shock. And no pulse, nothing. Nobody was there. That was afternoon, 1:30 to 2 o'clock. No nursing staff, nobody. And we revoked. That is lifetime experience, what I want to share.
Okay, very good. But the third one is irrelevant here because that has more to do with ethics and bedside manner, not as a student doctor. Okay, doesn't matter. Now we come back to this group, pink group.
Good morning, sir. This was our experience as a final year student. We had basically unit parties in our college. There was a trend like that. So there was this internship period where the intern and the PGs, everyone left. And they called me like I was, because the seniors used to teach for us mostly, rather like the PGs used to take class because we could ask them questions. So I don't know why I was chosen out of all the unit people, and they called me, Monica, just take care for a 1 hour. So I thought 1 hour, you know how to check vitals and all, you take care. So it was fine. But after that, they called at 7 and they turned up at 10. So I was really feeling like first nervous. I was calling them and they were like, we'll be back. Then at that point of time, I stopped panicking, and then I felt, no, next year I'll be a doctor within a 6 months or a 1 year. So that is when I gained the confidence and I could actually be okay with being a doctor for the first time, dealing with an AIMSU patients who are unstable, sir.
So during our college days, we had an exhibition, health exhibition for government Kannur, sir. So we had a health exhibition for our Golden Jubilee. So all the departments put their stalls. So we interacted with the normal people, society people. They came to the different stalls. So we as a second year department, as a UGPG, we interacted with the patient about how different diseases will be spread. So during that time, we felt like a doctor. Yes, sir. And usually in the dissection halls, anatomy, sometimes we as a UG students will be doing the cadavers. So during that time also, we felt something different from a regular student. Sometimes, like a doctor.
Maybe first two are okay. Third one is you did some activity. All are covered? Okay? Okay. Now, let me tell you, because he has brought that dissection hall, I want to tell you, see, the things are changing, and as each cohort is changing, certain things are forgotten. For example, when we were students, in anatomy, we used to study McGregor's surgical anatomy. So always we have to write applied anatomy. Green's applied physiology. And all these things were clinical pharmacology, Lawrence. All these things were there at that time. But over a period of time, when small books or shorter books have come, people have started preparing for exams rather than trying to become doctors. That's why we are rediscovering what has already been done. For you to understand, let me quote one example. When I was an assistant professor, one day I discharged my patient, and I saw the patient was still in the ward. I asked the patient, why you didn't go? You have been discharged. The patient says, my doctor has not come. I want to tell my doctor and go. Who is that doctor? First clinical year student. First clinical year student is the doctor for that patient, because we introduced, students, each student, they have to take care of one patient. That's how. So, at various places, these things have happened. And for many of you, how many of you are born before 1980? None of you? In this group, 1980. So, 1980. Then you must have been a child. Okay. So, 1977, there was a Rome program, reorientation of medical education program, where students were housed in a PHC for 15 days. Students, medical students with boarding facility in PHC for 15 days. Every day one professor has to go to that PHC. One professor by rotation has to go by public transport and stay there till evening and teach them. Now you see that fear of professor is gone. Fear of professor is gone. The college principal goes, HOD goes, other professors go, and from all departments they have to go. So now these things were there. Now we are rediscovering these things, that's all. So you are going through that. In the meantime, because it's as good as a flip classroom, all these things you can go through. I want to settle. Now let me tell you this student doctor, this is a new terminology. But then there was a terminology called clerkship, and it is nothing new. Clerkship is nothing new. See, the modern medicine starts from Britain and France. They introduced this clerkship. Whatever you call rotation, it is called clerkship, which means the student does the work under supervision of the doctor. So that clerkship word was removed and it becomes simply clinical posting. So as long as that word is there, that is, you can see in the college diaries of yesteryears, if you go through the program, there it would be written as clerkship program. The student the attendance has to be taken by assistant professor at such and such time. They will be allotted a patient, a discussion will happen, and they will do this, they will do that. All these things have been documented. Because those things were forgotten, because they are not implemented, now it has come back. There is one Dr. Rajendra Prasad, a neurosurgeon, who was a principal of SV Medical College at one time. He gave an exercise to the students of first, those who were in anatomy, when they were going for vacation. He said each student has to write a case sheet for a patient by interviewing for about a week for 2 patients, and they have to present it after they come back from vacation. Students are always smart, so they don't they cannot stay there during vacation. So before they go for vacation, they went and wrote, and they were all so enthusiastic and ebullient. They don't know who is who. For example, I was on a duty, and when student came and said, "Where is this ward?" I said, "That's the ward. Where can I examine the patient?" "Yes, go and examine," our principal has said. And when going, that student, I still remember by name, Aparajita. She came. "Thank you. What's your name, sir?" "I'm Dr. Sridhar." "Oh, thank you, Dr. Sridhar." And she went. And next, as soon as she completed, she came as a student to me. Then she, bites her tongue. And from that time on, she doesn't talk. Now you see, what is happening? What is happening? We are creating a sort of inhibition, social inhibition among the students. So, you may be knowledgeable. Student doesn't know, doesn't matter. He knows something. He doesn't know as much as you know. At the same time, you also do not know certain things. Now, to strike a balance, you need to give some space, freedom for the student to express themselves. But you can certainly correct. Certainly, you can pass comments. Constructive, what we call in a nuanced way, feedback, always certain things told very nicely, they don't remember. Sometimes, even a word spoken in a harsh manner, people, they recollect, they tell proudly, "My teacher scolded me." That was also a great thing. So, this as we say, medicine is a art and science. Teaching and instructing and making them learn is also an science and an art. Yesterday somebody said, so many things are there in education science I did not know. That was somebody spoke here, I didn't know. Now, when I went and asked my vice principal, AVS Saramara once, he said straight, see, the teachers after they get MD or MS, straight away they go to the class as an assistant professor, whereas a person who teaches a LKG, UKG, they have to go through a teacher training course. A teacher training course is not necessarily just giving instruction. It is understanding the student's mind, understanding the student's circumstances, understanding the student's potential, finding out the capabilities of the student and unearthing and making them do that well. So, in a way, now the NMC has started ACME course, Advanced Course in Medical Education, which was 1 year. Now they truncated it to 6 months. They will do it to 3 months. They will do it to 1 week. Now, whatever we are going through BCME and all for 3 days, it's only a sample. It's only a sample. So they have, because you are all adults, they have given you a sample. It is for you to explore further and read and implement in your day-to-day educational this one. Take teaching as a passion. Teaching is not a job. And caring is not a job. These are all passion, a calling. That means you have to endure so much of inconveniences to impart these things so that those people will flourish and they will take care of the society. They will be thankful to you. Now, this, whatever we are calling as bedside and all, these things are all nothing new. It was in 18th century, Boyer Howe of Europe who introduced bedside teaching. Now you see, some 300 years ago, and then Richard Cabot, he is the one who introduced case studies, and that was in 20th century. And then Osler, he is the one who introduced clinico-pathological conference and all. Even now, those things are all we can read in journals. So all these things have happened much earlier. So now we are only reinforcing those things, such of those things which we did not, which we missed in our preparation for examination, in our quest for examination. What is called missing the woods, trying to find the trees. The examinations are like trees, whereas the forest or woods is the whole gamut of learning. So now that you do not have those constraints, this is the time you discover the woods, the great aspect of educational science and apply it to medical science. Now, in this aspect, it's going, I think the various activities are given, how these activities are to be implemented, that's the question. Now, let me tell you, what is the mandate for this particular session? This session is to understand the principles of student-doctor method. Student-doctor method, that is, you give an activity and watch. For example, what is the success of this instruction if in the final examination the student cannot examine pulse properly, cannot record blood pressure properly, cannot use let us say any instrument properly. So what is that we have taught them? So make sure, we say we have to take a logbook, and in the logbook the activities have to be written and how many times they wrongly written till they successively they do it in a successful manner. 2-3 times you define it, they have to do it 3 times, correct blood pressure recording, then I certify this competency. Those things logbook. And in logbook it's only the activity. What activity? How many times? Then they have to maintain a portfolio. What you call by whatever name, they have to write in a journal or a notebook in which they have to explain in detail what they did. That in recording the blood pressure, I did these mistakes initially. I realized it. I did it like this. Then I used the palpatory method whenever I had a problem. And then I also remembered that there can be an auscultation gap which I have to check. Like that, they should write the reflection. When my teacher told, I thought it was like this, and later when I practiced, I got this doubt and I got it clarified with my teacher. So that's up, they should write those things, and then you give an assignment. What assignment they did? In a logbook they will write assignment for on this topic, so and so date. But the actual assignment copy should be there in the portfolio. So the evidence that they did those activities which are listed in the, so these are all the things which are required. So the principles of student-doctor method is, it's not the theory. Theory is already happening from first year to final year. And how these are all practiced in the what? In a, what is called a non-threatening and a safe environment. Non-threatening. The mistake done by a student doesn't cause any harm to the patient as well as to the student. Now, most of the time, while allotting the patients for examination, you have to be careful. I am a privy to 2 incidents when patients were kept in examination and they died during the course of the examination. So you have to be very careful while you select patients. So the postgraduate student or assistant professor or senior resident, whoever is there, they should properly allot the patient to the student. As soon as the student comes, there should be a method by which they report to a particular person in charge and he allots the patient to be examined. They cannot examine patients in a random fashion. So there should be some aim why they are examining this patient. Even if it is a quick survey of the patient, patient should be comfortable. So the first principle is primum non nocere. So you don't harm the patient. So that means you have to select a patient. And then examination skill, that is, patient should be comfortable and doctor should be comfortable. So how they come? And then to be seen as a doctor, it all requires, in Tamil there is a proverb, alupadi, adaipadi, which means half of it is your persona and half of it is your dress. How you are dressed, how you are groomed, and that grooming is very important so that you have a halo around you when you go to the patient. So in fact, once I made 2 people go to, on a Sunday, I saw one house surgeon was he was wearing a t-shirt, apron and all, and another person was having an apron and all. I took both of them to the patient and asked, who is the doctor? Though they have been seeing them daily, they identified the person with the apron as the doctor, whereas the person with the apron, with the t-shirt, he was simply ignored by the patient. So these are all very important. These may appear very silly, But then, these are all very important because the hospital and college is a noble place. These are all the temples. So when you go to a temple, how do you go? So those things are all important. These are all some of the principles of this. Then implement structured clinical teaching using this approach. Structured clinical teaching. That means from simple to complex. Simple to complex. You can start with a complex topic, but then break it into simpler and then teach them for the benefit of the student. You are not exhibiting your scholarship before the student. Student has already agreed. You have been given the designation that you are associate professor, you are a professor, you are assistant professor. So there is no need to exhibit your knowledge in that position. You want to exhibit your knowledge, go to a conference, participate in a workshop, and there you exhibit your knowledge. Before student, you need not exhibit your knowledge. You are knowledgeable, he acknowledges. And now you see how he learns, how you are able to transmit that knowledge to the student in a way that student can remember for his life. That's a very important thing. Not only that, he can improvise over what you have taught. I still remember in an examination in another college, Biology Medical College, when I asked a student to examine for apical impulse, normally we say either he should be examined in a sitting position or in a supine, in a left lateral position. But one boy, he examined in a supine position, he put both his hands on the chest, right and left. I asked him why you did. Sir, in case the patient has got a dextrocardia, I can detect it. So nobody has taught it. And in a book, the apical impulse is described as lowermost and outermost point of definite cardiac pulsation. And a point is a point, but it has got an area. One student said lowermost and outermost area of definite cardiac pulsation. So that's the improvisation. We should appreciate. Don't say that it is given as a point in Davidson textbook or Hudson textbook. They are also human beings. They wrote at that time, and if our student improvises it, you better appreciate whatever they're doing. So it's not only you are transmitting the knowledge, you are also creating a scope for the person to enhance and exhibit his ability to improvise that knowledge. That's also good. Then the incremental responsibility. They progressively take on the clinical responsibility. Now, as Dr. Monica said, the students, they go to AIMSR in the evening. So this practice is there in many medical colleges. The students posted in a unit, they go to the acute medical care on the day of posting, on the day of OPD, and spend some hours. If there is an accommodation, they're supposed to stay there. Actually, these postings have been recommended in all departments for a short while by rotation, and only OBG department implements it. OBG department is the only one where people are posted who stay there and conduct deliveries, and in all other departments by default we are not conducting. And I appeal to our Associate Dean to see that these are implemented, however crude it might be or however small measure it might be. These things have to be implemented for the student doctor learning has to occur. Then experiential learning. So there are learning. See, you have to read learning theory. As I already told you, it's nothing. So the psychology of learning theory, only psychiatrists they know. Psychiatrists and psychologists, they read a lot about learning. So learning, superficial learning, deep learning, semantic learning, and experiential learning, transfer of training. So many things are there. How to memorize, the theory of memory, theory of forgetting. So many things are there. So those, without all those things, we are looking at a very narrow mind. It's in the book by, Medical Education Technology, published by JIPMER, edited by K.R. Sethuraman, where they say, everything for a non-medical people, everything in medicine is a miracle. For a non-medical people, medicine is a miracle. And for a medical people, everything else is a miracle. Everything else is a miracle. So let us try to broaden our knowledge in other sciences, because adaptation. No, community medicine people, anybody is here, so they can understand in their healthcare administration or healthcare management, most of the things, they're all adapted from military science. So adaptation is very important. You don't borrow it straight away. You modify it to suit to your convenience. That is the most important thing. So experiential learning, because what the person experiences, he remembers well. So create opportunities for the student to experience, and then supervised decision making. In decision making, you ask for a diagnosis and don't discuss everything straight away. Ask the student to tell why you are making this diagnosis. It may be wrong, it doesn't matter. Why you are making this diagnosis? What are the points to say this is? And what does the literature say? So that is how you start giving a chance to the student. That is supervised decision making. Clinical reasoning is honed with a faculty guidance. So faculty has to guide. They have to guide them to reach the solution. When you say differential diagnosis 1 to 4 or 1 to 12, and you zero it on 4 or 5th one, and why you are zeroing on 4th or 5th one by your observation and all, that you have to make it explicitly clear to the student to understand. Don't imagine that they will learn on their own. They will do, and according to their temperament they will do. But then we are charged with the responsibility of making it easy for them. Not necessarily easy, to do it in a scientific manner. For the onwards, let me tell you, there were a series of articles on clinical judgment in 1970s, which was further summarized as a textbook on clinical judgment by Alwan Feinstein, which was published by, I'm not sure which company published it. It's there. So in which clinical decision making is so nicely given. Later there is one by Greiner, an article that came in, what is that? Annals of Internal Medicine. Annals of Internal Medicine. So a 40 plus pages article. And then we got the major one in the last 10 years, that by Sox, who is that? Sox Jr. So that's evidence-based medicine. Evidence-based medicine, and that has taken over. And these are all evolved from the preliminary ones. So nothing happens, nothing comes just like a bird from the blue. So it's all evolving, one step at a time. Similarly, you make this, do that. Then comes the most difficult one. Okay, faculty supervision and feedback. Most of the time, we do not give feedback to the student. Most of the time, we don't give feedback. We imagine that we give feedback. On the other hand, we would have given only reprimands. Not exactly feedback. Feedback means we have to clearly find out which aspects they did well, which aspects they have to improvise, which aspects you are willing to help them. All those things have to be told. It's not just a good, all right, excellent, nice. Those are all fine. But then that's not exactly the feedback. It has to be objective. It has to be objective. He says, I thought like this, I gave like this. We can ask, you can always say, why the alternative way of thinking could not be done, and how it could have been done if you had gone through in an algorithmic fashion. Now, there are two ways, heuristics and algorithmics. Sometimes, when you have seen number of patients, you get a gut feeling that this is so. Okay, gut feeling is the initial one. And then, going through in a systematic manner, you get algorithmic and you get it. So that's it. So then, then feedback and reflection. Reflection, vaguely we say reflection. So your lecture was very good. I learned many things in your lecture. What many things? Which aspect you learned? Which aspect you did not know earlier? Which aspect which additional points you learned, and why in the earlier time you could not learn that. All those things the person should reflect, and it cannot be done in reflective writing for every session is not possible. So you have to give time, maybe a weekly reflection. So summarize what happened during this week, what all that, because it has to sink into the mind. On the spur of the moment, they may write many things. Actually, learning, it said, is what remains after you forget everything. So learning is what you remember after you forget. So give 1 week time for the person to forget, and then let them write what exactly they remember. So that's what is going to remain in the person for a long period of time. And you find that important things are missing. That means there is something wrong, either with the student or with the teacher or with the environment or with whatever it is. And so that's the issue, teaching issue or teaching learning issue, which you have to address and see that the student, not only that particular student, others also benefit. So that's a faculty feedback. Faculty observes, corrects and guides the student. This OSI is nothing but you allow the person to do something and wait till the person completes the exercise. Then you correct. So if you're meddling at each and every step, the person cannot progress. He feels paralyzed. So allow him to complete the task. And you note down what are all the mistakes or what are all the things he could have improved, and then in a neutral way you have to tell the person this is how you could have done it. Then communication and clinical skills and reasoning. Communication, it doesn't come just like that. Again, it's an art. Some people, they have got the innate skill of making friends and talking and making people comfortable. So, but then, very nice thing is, one of the things that breaks the ice is a smile. If you can smile at the, not a sardonic smile or a, what I should say, a sort of sarcastic smile. It has to be very neutral and encouraging smile that dissolves and they can learn. Communication, non-verbal communication is also very important. So when you are observing the teachers, students, you know whether the student is understanding or not. Is there any problem? The student, is he having a quizzical faces? Then what's the problem? Anything? Any problem? Should I repeat this? So we can always ask. And that's a very important thing. Then reflective learning is students analyze their decisions. That is, during self-directed learning or self-learning, they can analyze, identify the learning points, and faculty facilitates debriefing sessions. So when they come back and tell you debriefing, why this is okay, why this is not okay, what went right, what went wrong, all these things have to be done. So that's it. So summary, very nice, very summarizing, program evaluation out there. Then, active learning, that is, student is not passive, sitting, and you are talking, you are hypnotizing, the student sleeps. He is hypnotized, he is sleeping. So everything's gone into us. So make the person get up, do something, tell. So all these things are all important. So active learning. So in student doctor, this one, the student becomes active. Student talks with the patient. You are a bystander looking at a somewhat in an unobtrusive manner. So they are interacting, I am staying here. From here I am observing what they are doing. Otherwise, you both of you interact. Then what do they interact? They cannot. So it has to be unobtrusive. So, and of course we have to see people and this thing. Then responsibility. This is not only active learning. You tell them you are responsible. If you record, so I can tolerate mistakes for 4 times. After that, I think I cannot interest you with this. You have to again start from the beginning. So we have to tell. So that's why, in JME, or they say it's not time limited. It's not time limited. It is competency. So the student can stay there for 10 years. One of the mistakes all government medical colleges and private medical colleges, save for few, the mistakes that they do is sending all the students for examination, whether they come to the class or not. That's wrong. Yesterday, one house surgeon came, whom the medical superintendent said, discharge him. Discharge the intern. What do? Throw him into Bengal? Why discharge? He comes without a stethoscope. He writes a prescription without signature. He never attended a class. How he is sent for examination? How he passes the examination? These are all the things I take place with Padmavati. You gave a question yesterday. This is the risk I am taking of talking. You gave a question to me. I answered just now. Last. Okay. Then it's over. Summary. Decision making, ensuring a smooth transition from medical student to intern. So that completes my task of informing you something about how to go about student-doctor method of training. Thank you. If I got any doubts, one or two doubts I can take, though this is a topic where we need a lot of time, doesn't matter. Now, if you can, just one or two questions I can take. Feel free. If you are not asking questions, do not expect your students to ask you questions. I am soliciting a question. Whatever you want to ask, or you share an experience. Anything. Just 2 or 3 people. One group each, 1 minute. Please. Quick. Something.
Sir.
This is an important thing. Otherwise, pass it on to one of your group.
Sir. Right, sir.
Quick. This group. Why do you want to pick up from this group? This group. Somebody. This group. Stop. You.
Sir, like you told, a few students, they are not attending classes at all. Sir, how can we expect a doctor-patient relationship to develop? And they are...
That's what I am telling. That's what. If the mountain doesn't come to Muhammad has to go to the mount. Now, it said, there is one Dr. Pai, who was a principal of SM Medical long back when the college was started. He would sit with students or go to the student. There were teachers who goes to the student and brings them for examination also. So, somehow you have to create interest. See, you can take the horse to the pond. You cannot make it drink, but make the horse thirsty so that it will drink. That means you are abandoning your students. One more time.
Sir, but when I was an undergraduate in second year and third year MBBS, I had a good interaction with my doctor, sir. That is you.
It's okay. So, what difference does it make? What difference it made? You tell.
Sir, you have told us that patient is important. Patient care is very important. Never neglect the patient.
Patient is important?
Patient care is important. Never neglect the patient.
No, sir. Just one question, sir. Last. You said that irrelevant, no, sir. Irrelevant, you said, no, sir. When I asked that this thing, why? Because we are training. That was in no, sir. Ethics, sir.
We'll discuss it later.
No, sir.
We'll discuss it
Sir.
later. Please. No.
Ethics and communication. Communications.
This is not the time.
No, sir. I'm not doing that,
discuss
sir.
separately.
Ethics and communication.
We'll discuss separately.
No, sir. Just ethics and communication is very
Agree.
important.
We'll discuss it.
Front of students.
That's what we do.
Sir, we want to teach them, but that interest should be from both ways, no, sir. Nowadays, students are not that interested.
Think about your own studentship. Very, very active. You are very active. You are outgoing. You are talking with the teachers. All that you did is you went to class regularly. You had 100% attendance, probably. But did you talk with your teacher? Few of them. So take that as a cue and you start talking. So the conversation is to be made. I forced you to talk with me. I forced you to talk with me now. Quick, 1 minute. Time is up. Except you.
What I was.
Sir, I have
You can talk later on.
So you're taking so many risks. How are you dealing with the risks?
Not thinking that it's a risk. That's my duty.
Yes, sir. Small thing. Nowadays, students are not respecting their teachers, sir.
You have to command respect. Thank you, Dr. Lokesh. Thanks, the organizers.
Thank you so much, sir, for a great interactive session. We'll all break for a short tea break, followed by a group photo here.
Anyway, something comes to my mind, I must tell always. Probably this could be my last interaction because I also lost passion for all these things. For past few days, I am very passionate in whatever I am trying to do. I want to gradually disengage. Thank you.
Please take a short tea break and come back quickly for a group photo session, followed by the other sessions.
Okay, I request all to please assemble for the photograph, group photograph, and then we'll start the session. So kindly come over here.
Okay, ma'am. Okay. Now, table play again. ఇలాగే ఇలాగే ఇంకా అలాగే ఇంకా అలాగే ఇంకా అలాగే ఇంకా అలాగే ఓకే మ్యామ్. ఇది కూడా ఆ పక్క ఇంకా లాక్కోండి. ఓకే, ఇది 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 ఫొటోస్, ఇది అది వీడియో మ్యామ్. ఎట్లా ఉన్నా పర్లేదు, కొంచెం చూసి వైరు. ఇల్లు చూడండి మేడం. సార్, హలో సార్, అది బ్యాగ్. సార్ బ్లాక్ షర్ట్ సార్. సార్ కొంచెం ఓకే సార్. ఓకే సార్, కొంచెం మేడం. ఓకే సార్, కొంచెం బ్యాక్ సార్. సార్ కొంచెం ఫ్రంట్. ఓకే ఓకే సార్. ఓకే, రెడీ రెడీ సార్, రెడీ. స్మైల్ స్మైల్. వెయిట్ 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 మ్యామ్. వెయిట్. ఓకే ఓకే, రెడీ రెడీ మ్యామ్. ఓకే సార్. ఓకే, రెడీ. వెయిట్ మ్యామ్, వెయిట్ మ్యామ్. ఓకే, రెడీ. స్మైల్. ఓకే, థమ్స్ అప్. ఓకే, రెడీ రెడీ మ్యామ్. వెయిట్ 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 వెయిట్. వన్స్ మోర్ వన్స్ మోర్. ఓకే సార్. ఓకే నా అట్లా వెయిట్ వెయిట్ సార్. వీడియో ఓకే. ఓకే సార్.
That is error. Use your own.
Good morning. Good morning. Good morning. Wow. This response, this chorus response is what gives the energy to start up. So, I think by the time I say thank you, it will be afternoon. So, I have a long session to go. I'll be starting with skill development and training. Okay. So, what do you think skill is? Any of your definition what skill is? A special talent, right? Agreed? Sir?
Activity.
Acquired activity, yeah? Okay. But to be very simple, the Oxford Dictionary says, whatever you do perfect or the best is the skill, right? So, this slide is taken up from the NMC. So the purpose of skill training is to enable faculty to develop and implement skills training as part of implementation in the new undergraduate curriculum. Okay. So the objectives of today's talk is, at the end of the session, the participant will be able to understand the concept of skills, competency and the role of skill labs, apply the principles and steps of skill development, develop an outline of a skill module in a given scenario, reflect on and discuss about the process of skill development, and review principles of skill assessment. So the summary of this slide says, you should be able to identify a competency, develop a skill for it, make the learner perform it, and then give a feedback. That is as simple as what this slide says. So this is again taken from the GEMR. Yeah. I've already asked you what skill is, right? So, on a lighter note, I am skilled at sneaking in and out of my house when I go out for late night parties, and trust me, no one even knows when I'm in and when I'm out. So I'm skilled at that. Yeah. So someone can, I think I'll ask Anusha to tell me a skill of Uday that you like.
Sir, if any situation or any problem, it might be professional or personal, he'll have some or the other solutions, sir. Right. So I like that without getting panicking and all.
So he has a solution for all problems. So Uday, whenever I have a problem, I'll come to you, right? Yeah. So any skills? Jyotsna? A very important person of the department, please. I don't want professional skills. I know you are good at teaching, I know you are good at shouting, I know you are good at doing surgeries, but tell me a skill that, is not professional.
I can make an introvert also as an extrovert when they make a friendship with me.
Okay. Good. So when are you making the new PG as an extrovert? Our new PG is a very introvert, so yeah. Any fun skills that someone has and that can be shared? Anyone?
In casualty, we do mostly panchayati since.
I don't want professional skills.
This is not professional, sir.
That is also a part and parcel of an emergency medicine.
Doing panchayati also, sir.
Of course. Yeah. So, in our context, in today's context, so any action by a healthcare practitioner involved in direct patient care which has a measurable impact on the clinical outcome is defined as a skill. Okay? So, skills are again, it could be cognitive or intellectual skills, psychomotor, communication, or with teamwork. So, I don't want to get into the matter, I'll just tell you very simply. Cognitive is something that you do with the brain, right? Psychomotor is something that you do with the fingers or the hands, whereas the communication is something that you do with the mouth, okay? So these are three different important skills that one should have. So again, it is again classified as technical and non-technical. So examples of technical skills: history taking, physical examination, communications to the patients, procedural skills, information management. Whereas non-technical are situational awareness, task management, communication with the team, decision making, and prioritization skills. So what is a non-technical skill? Technical skill is something that is cognitive, social, and personal resource skill which has an impact on the outcome of the technical skill. So competency and skills, competency is a word that day in and day out after CBME has come, we get to hear, okay? So competency-based medical education is an outcome-oriented one. The learner is expected to be able to demonstrate achievement of a predefined skill, okay? Right, so the document on skill defines levels of competencies for different skills like knows how, shows how, and to perform. The general principles of skill acquisition is that, the skill is already predefined. It is given for all phases. Like each phase, one skill has to be done. And it is also present in the document, which is a certifiable skill, which the student has to do it, okay? So, it is completely predefined. The skills that are present are completely predefined. And the person who is doing it, and the student has to repeatedly do it till he achieves a perfection. That is the principle of skill acquisition. Right, I know you can't see me and hear me for long, so I have the next speaker to help me and guide me. Madam, Ramya Madam? Yeah. So she'll take the session further.
So good morning, everyone. Thank you, Dr. Siddharth. So as you all know, sir has just brushed upon the types of skills and about skill skill training. So we'll move on to the next concept in the skill training. Now this is a little, I would not say tricky. There is something called as a criticality and feasibility. So what do you understand by the term feasibility? Feasible means what? Possible. Feasible means what? Any other word? Easy, ease of doing it, the comfort, the convenience. So what all factors do we take into account when we think of feasible, being feasible or doing it? Infrastructure. Anyone? Resources. The type of skill itself, very good. Support. Sorry? Learning? Learning curve, okay. So we should know whom we are teaching, the time, and like all of you said, resources, the type of skill. All these things matter to say whether a skill is feasible or not. So what do we understand by this criticality? Difficulty level, yes. Yes. Complexity. Anyone? Importance. In what way, sir? Importance? In our field, in medical field, importance in the sense? Patient. So overall, we have to say how useful it is for the patient, how it is going to impact the treatment, how it is going to impact the patient outcome. So that is what we mean by criticality here. So there is something called as we have to relate criticality and feasibility. So there are 4 domains in this. So the first domain, if we take, it says low criticality and high feasibility. So what do you understand by this? High feasibility but low criticality means what? We can easily do some procedure, but it is not so important when we look at patient care or patient outcome. So they have said certification of independent performance is not essential. So we don't have to certify it. It's good that the student knows about it, that the student can do it by himself, but then you don't have to certify it. So we can give them opportunities to observe or assist in such procedures. The next is high criticality and high feasibility. That means it's extremely important for the student to know and to perform. At the same time, it is easy to do. Now these skills have to be certified, because we can do it and it is also very important. The next column is low feasibility and low relevance. So what do you mean by this? It's not easy to do it also, and it's not very important also. So remember, we are talking about this for a UG student. At the level of an MBBS graduate, we are talking about these skills. So next column is low feasibility but high criticality. Very important, but then we cannot do it on anyone and everyone, but it's very important to know. So for these skills, they recommend using skills lab or simulation lab before doing it on an actual patient when we get a chance or when it is required. Okay. Now I'll just give a small activity. We'll give 5 skills, general skills, not medical skills. I want you to categorize them into 4 skills. I want you to categorize them into these 4 boxes. Which of these boxes it fits in? So say swimming, cooking, driving, and one more, stitching. Swimming, cooking, driving, and stitching. Okay, so red group, swimming. Green group, stitching. Yellow group, driving. You can share the remaining. Cooking, yes. You can share cooking. Or you can think of some other general skill and put it in a box. Sorry? Horse riding. Okay, so horse riding for this group. Now, this is just a general example for us to understand this. We have another activity following this. Done? Other groups ready? So you can tell.
Swimming, low feasibility and high criticality. Low feasibility, so the ease of doing is not very easy, and high criticality. So you need to know how to swim if you want to survive. So red box, ma'am. Red box.
So group red says swimming comes under the red box. That is low feasibility and high criticality. Yes. I was thinking, yeah, low feasibility is correct, but low criticality, I think it should fall in the blue box. Sir, the thing is, now swimming, if you say in general population, everybody need not, I mean, we cannot train everyone. If somebody wants to learn, we can pick them and we can teach them. So we feel it falls into the blue box. That is low feasibility and low criticality. Thank you. Green group.
Stitching, ma'am, low criticality and low feasibility.
So stitching falls into the, blue. Blue only. I think we can agree upon that. Thank you. Thank you.
Madam, driving, low feasibility, high criticality.
So driving falls into the red box. It is low feasibility and high criticality. Do we agree? We can't just take a new car and start driving, isn't it? So first we need some training. Thank you.
డ్రైవింగ్ బ్లూ అన్నప్పుడు హార్స్ రైడింగ్ కూడా బ్లూనే చెప్పాలి. డ్రైవింగ్ కూడా డిఫికల్ట్ అని నేర్చుకోవాలి. హార్స్ రైడింగ్ స్విమ్మింగ్ అయినా అంతే.
Because he's saying swimming is very critical.
At least driving అన్న క్రిటికల్ వాళ్ళు.
Ma'am, it's green box, ma'am. Cooking.
Cooking. So pink group has got the skill as cooking. So they say
green box.
Green box. Can you justify?
Ma'am, it's a mandatory thing that every day we go into it, so it should be known for everyone. Everyone should
Cooking.
know. Yeah, equality, ma'am.
Contrary
Equality
to common
should be there.
belief, everyone should know cooking. So I really appreciate.
Thank you, ma'am.
So it falls into the green box. Yes. Good. Thank you. Next, blue group. Their skill is horse riding. Okay.
Falls into a yellow box.
Yellow. So please remember, this is for the common man. We are talking about a common man. Like how blue box. Correct? Green? No, it's not.
Yellow or blue?
Yellow or blue? I think blue. It fits blue.
It's difficult to learn. Not that critical.
It is not that critical. Everybody need not know horse riding. But why is it yellow? It should be blue actually, because you know how what is the cost of going for a horse riding class? The Aam Aadmi can't afford that, and it is not required. So therefore it should go into the blue box and not the yellow box. Training is also not very easy, right? It's going to be expensive. You cannot train everybody to do a horse riding, and it is not required also. Therefore it goes into the blue box. So every skill that you teach or you learn, you try to fit it in your daily activity skill itself. You try to fit it in with regard to the requirement for day-to-day living, with regard to the amount and money spent on training. That is how you should match it. Okay. So I think yours now goes. Are you convinced it goes into the blue box?
Yes,
No, many of you are not convinced. Your classmates are not nodding their head this way, no nodding. What is this? Okay?
Yes, yes.
Right. So, no, you have to be convinced yourself, just because it's not I am telling, but you should be convinced as to whether you require to know the skill, the common person, and how difficult it is to train and certify that. These two indices you keep in mind, any skill you can easily put it into one of these 4 boxes, right? Okay, the next group, Dr. Ramya will take over.
Thank you, ma'am. So we finished all the groups. Now before moving on, I want each group to identify one skill. I will allot the box. Driving went into red box. So we will allot one box for each group. You have to identify a medical skill which fits into that box. 5 minutes activity, okay? So the first group, this is group. Red group will get red box. Green will get green. Yellow will get yellow. This is blue will get blue, but pink will also get green. The group pink will get a green box. So 5 minutes, identify any medical skill at UG level.
Where skill not useful.
Which an MBBS graduate is expected to know once they graduate, not for specialists. Please write it down and one of you can present.
Playing golf అట్లా ఏమని చెప్పు. Playing golf అట్లా ఏమని చెప్పు. Medical skill.
One medical skills.
Difficult to learn, not easy to learn, but not useful.
It can be a psychomotor skill, it can be a cognitive skill, it can be a communication skill, it can be any type of a skill.
అవన్నీ యూస్ఫుల్, అవన్నీ క్రిటికల్ కింద వస్తాయి. MBBS.
You can ask question of you can tell the
Your box is the easiest.
Yes. Do some track administration. I feasibility, highly critical. What to the
Are we done? All the groups are finished? We'll start with group blue. Finished? Finished?
Any surgical procedures, ma'am?
So what box have you got?
Blue.
Team blue has got blue box. So they are telling?
Any biopsies or surgeries?
Biopsies or
surgeries.
For MBBS graduate.
Yeah, for MBBS graduate. So an MBBS graduate does not have to perform a biopsy. Yes. It is enough if they know. Yes. Yes, if everyone is finished, can we have a discussion now? Group red is finalized. I think I'll ask you to present first. So what box have you got, sir?
Red
box. So what is the skill you want to put it in that?
So endotracheal intubation.
Yes.
Lumbar puncture.
Lumbar puncture.
Incision and drainage.
Okay.
Of abscess.
Okay.
And bone marrow aspiration.
Okay. So these are all some complex surgical procedures which it's really useful if you have to know it,
yes.
But then you cannot. It's not so feasible. So you have to do a demo on the mannequins first in the
yes.
skill lab. Do all the groups agree on that? Group yellow is still discussing. Okay, now we'll move on to group yellow. I think we'll finish. Yeah, present, sir. What is, you got yellow box. The other groups, please listen.
Urine dipstick for sugars. Highly feasible, low criticality. Urine dipstick for sugars. Urine dipstick that meant. Highly feasible, low criticality, man. Yes, madam, highly feasible.
It's highly feasible.
Feasible. No. Man, urine.
Madam, communication.
Communication pakka green.
And easy.
Wound dressing, yes. Wound dressing we can say. That is also important. But the thing is, certification is not necessary. Yeah, something like that. Yes, that also. You can modify. Has to know. POP slab, yes. That also I agree. Making a POP slab is also falls in the yellow box. Okay, done. Next, this over. Group green. So green group has got the green box.
Checking blood pressure, pulse rate.
Yes.
Doing basic BLS.
BLS.
Very important and very.
BLS is not
basic life.
It's not highly feasible. Every day you don't get a chance to do BLS on some patient, isn't it? So BLS will not come into the green box. Yeah, BP, pulse rate.
IMIV, subcutaneous injections.
IMIV injections.
Catheterization.
Catheterization, very good.
Ryle's tube aspiration, stomach
yes,
wash.
Yeah. So all these skills will fall into the green box. BP pulse. Ryle's tube they said. No, Ryle's tube will come into the red. Ryle's tube will come into the red box. IMIV injection is, I think it comes into the green.
Even IM injections for undergraduates. We cannot make all the undergraduates to perform.
Red.
Sorry. Right? You're telling it comes in the green box. So, is it highly feasible to teach and assess IMIV in on patients? 150 students, you're working with 150 injections.
So mannequins means it should go to the red box.
Okay? So, it is a very important skill to know, but you cannot feasibility of teaching it. See, this side feasibility of teaching, remember it is on the patients for us. We are now not the arm army, we are looking at MBBS students. Right? So feasibility is teaching on actual patients. What is the ease of doing? I don't think I need a break. What is the ease of doing? Is it feasibility of cardiovascular session. So that is the, therefore BP pulse 100% I agree that has to be
And any other general physical examinations, all that will go into the green.
Some of them will overlap actually. Some of them will overlap.
Yeah, there will be an overlap. All that will go into the red. Green. Nebulization will go into the green, I think. Yeah, all the general physical examination parameters will go into the green. Yes, all that will go into the green. Thank you. So blue, team blue got the blue box. I think I'll have to ask them again, sorry.
Any biopsies, liver biopsies. Or some.
Taking a biopsies, yes. Do all the other groups agree? The blue box, low feasibility and low criticality. We are talking at an MBBS graduate level. So they said biopsies. So it's enough if the MBBS student knows what it is, how it is done and its relevance. Okay. So thank you all the groups. So now that we have an idea, not done? Sorry. Green group. That was pink group, so I allotted green.
History taking.
History taking, yes. Only one? Communication skills, very important. I think this is the only group who told communication. Other groups told all of psychomotor skills. So good. Dissection. Dissection. Red, I think. Red only. No mannequins, but no, dissection itself means you are doing it on a cadaver, so it should come under it. Anatomage table, we can do it on that. Yeah, okay. So now they have given one example, like all of you told, it is demonstrate basic life support in a simulated environment. So what box does it go to? Red box. Automatically it goes into the red box because the feasibility is very low and criticality is high. So the most suitable environment for that is a skill lab training using simulation. Another example they have given is diagnostic nasal endoscopy. So what is the feasibility? Feasibility is low, criticality is also low. So for an MBBS student, being aware of this skill is sufficient. So obviously it falls into the blue box. It goes into the blue box. Now they say performing and interpreting ECG. What box does this go into? Let's say only interpreting ECG. Let's not say performance. Let's say only interpretation of ECG. Red box. No. Sorry, it goes to the green box. Just interpretation, isn't it? They have the ECG is there and they just have to interpret it. So it goes into the green box. If they have to perform, then it will go to the red box. So only interpretation, it will go into the green box because it has got high feasibility and high criticality. An MBBS graduate is supposed to interpret an ECG and take some decisions. So I hope this concept of feasibility versus criticality is clear. Okay. How to teach, how to plan to teach a skill session? I'll take inputs from you. What are the steps you take to organize? How do we teach a skill session? You have to plan a skill session. What is the first step? First, you identify what type of skill you have to teach. Next, objectives. What else? Infrastructure, space and resources. What is required for that? You need faculty, you need the right number of students. Anything else? Time. Most important, time. Right now, we are facing, that is the most important constraint we are facing. There is no time. And it's always better if we schedule it ahead. When we are planning the curriculum itself, it is better to allot some hours for skill teaching. So skill, like we all said, need not be always psychomotor. It can be any type of skill. Always teaching a skill need not be in the skill lab. All the skills need not be in the red box. There are other skills also which fall in other boxes which you can teach anywhere. In a clinical setting, in a classroom, anywhere we can teach the skill. Okay. So these are the types of skills you all know already. So what are the issues with skill teaching? First thing, number of students. We all have 150 students. So teaching 150 students is no joke. Time constraints, most important factors, though we have the resources, though we have the space. Manpower, yes, I agree. So there are different levels of learners. So we have to cater to the needs of different types of learners. Somebody grasps very quickly. Somebody does not require any assistance, they will learn by themselves. And there is the other category which we all know. We have to do everything, still it's very hard for them to learn. So we have to make a module wherein we can fit teaching all different kinds of learners. Patient safety concerns, that is if we teach something on the patient, mostly we teach examination. How to examine, and at a higher level we teach some specific procedures. Constraints in providing developmental feedback. So these are the whole spectrum of teaching learning methods. So if you see on the left hand side, they have enlisted the teacher-centered learning methods. On the right hand side, we have the student-centered learning methods. Now if we actually see, there is a space in between. That is what is most useful. There should be a mix of both teacher-centered and student-centered learning approach. So I'll not go into the details of all this. We all know already the teacher-centric and the student-centric teaching methods. Now how do we teach a clinical reasoning skill? We are all doing it. How do we do it? Case-based, exactly. We give at first year level, because they are not exposed to patients, we give them a case history and ask them some questions and ask them to reason out, give some important points. In the hospital, we can actually show a patient and ask them to examine and do it. So here there is a technique called as a think, pair, share. It's like we give them a scenario, or we give them a patient or a question, ask the person to first analyze by himself, think and analyze by himself, then share it among his peers. Then one person will come and interact with the whole class. So that is the whole meaning of this think, pair and share activity. So these are the different strategies to teach clinical reasoning. There can be a clinical encounter, clinical case presentations, which is commonly done in the bedside teaching, case-based discussions or a chart, stimulated recall, clinical problem-solving exercises, structured case presentations, SNAPS model, and 1-minute preceptor. So I will elaborate only on this 1-minute preceptor test. So what is this 1-minute preceptor test? It is a method of teaching a skill in the hospital, in the bedside. So when a student comes and gives a history or a finding after examining a patient, these are the points which we have to take into consideration. First thing is you ask for a commitment, probe for supporting evidence, provide positive feedback first. Tell them what they did very nicely, then identify the mistakes and guide them accordingly, teach a general principle and then conclude. Now another small group activity just for 5 minutes. Consider this scenario. Consider this scenario. A 45-year-old male came to the clinic with persistent cough for 3 weeks, mild fever and weight loss. The patient had a history of smoking 20 pack years with no prior history of tuberculosis or chronic illness. Now I want you to analyze this in this method. I'll just show you the first one. Get a commitment. So the doctor asked the student, what do you think is the most likely diagnosis? So I want you to do the rest of the steps. You want the question? This is the scenario. If a student comes and tells a patient about this, I want you to guide the student under these headings. Question? You want the question? Previous slide. Are all the groups done? Yeah. We'll start with group green. Yeah, other groups, please listen. They are present. Yeah.
So we will ask.
Little louder, sir.
So we'll ask them what their provisional diagnosis is.
Okay.
Then probe for supportive evidence. We'll ask what their positive findings in general physical examination.
Okay.
Local
Positive finding in the sense?
what are all the findings that support his provisional
Whatever
diagnosis?
provisional diagnosis they have come to. Okay.
Then they'll have to do respiratory system examination.
Yes.
Check all, take a thorough history.
Yes.
Then go through all the investigations what are available.
Okay.
Then provide positive feedback. So how good history taking and how they reach the diagnosis.
How do we give a positive feedback? What do you say to the student in a positive way?
Very good. Good. You have done a good job.
Yeah, you have done a good job. Yes. So that is the next step. So next step, you guidance and errors. Yes. Exactly.
About appetite and
yes. Okay. Okay. Next. Yes. And tell them that next time you have to examine all this, you have to make a list, keep all these things in mind. And then finally,
feedback.
Conclusion. Give a positive feedback and say this is how it has to be done the next time. Good, I think they've done a good job. Thank you. Group Yellow.
No, ask for a commitment for chronic bronchitis. Pro for supporting evidence. Chest X-ray. Student to do a chest X-ray. And sputum for CB-net. Provide positive feedback. Tell the patient the diagnosis and his relevant findings are good. But next, coming to guidance. Tell the patient also to take occupational history and family history, which should not be missed, and the environmental history should be considered. General principles: don't make the stop smoking, and take the guidance and do a proper case presentation next time.
So I think they have covered all the aspects. So they said get a commitment, ask for a chest X-ray, you give them a positive feedback, and then say next time you have to do this, take occupational history, which was very important, and then advise them that stop smoking from now on and change your lifestyle. I think they did very well. Thank you. Red group.
As for commitment, we need to ask what was their diagnosis, and for supportive evidence, we can give us symptoms like cough, weight loss, and history of smoking. They can present in such way. Students can say these were the positive factors, provisional. And positive feedbacks, we can appreciate the patient. I mean, we can appreciate the student how well they have presented the case, or how well they have done. In guidance, we can show what errors they have done, what could have been added to the case, or what error. Night sweats. So we can guide them what errors they have done, and we can even tell them what can be added to the case. Then teaching general principle like case presentations, how to present a case presentation or examination of the patient respiratory systems and all. So by conclusion, we can see the summary of the case. We can say.
Thank you. Group Pink. Anything to add to that? Nothing? Sure? Okay. Thank you. Group Blue. Same thing? One thing which I thought was missing in the last two steps. Sir? Okay, what they have learned, so their reflections. You ask them to write there, or their reflections, yes. One thing I thought was relevant is, it's a tuberculosis case. I think we have to spread some awareness. In the last step, ask the student to tell the patient about the disease, how it is transmitted, what precautions they have to take, a general awareness about the tuberculosis disease itself. Okay. Thank you to all the groups. So next, so this is the scenario. So get commitment. What do you think is the most likely diagnosis? So you can say chronic bronchitis or tuberculosis or lung cancer, it can be anything. Probe for supporting evidence. So this is the way we have to ask them, what findings led you to this conclusion? So the student might say some positive history points, some investigations which are supporting the diagnosis which they have given. Reinforce what was done well. So like they said, we say you did a good job. Differential diagnosis, you thought of TB and you thought of chronic bronchitis, so you have done a pretty good job. You also picked up on some weight loss, which was an important symptom. So things like these, we can give a positive feedback to the student. Correct mistakes and provide guidance. So they say, like one of you pointed out, next time consider getting a chest X-ray to rule out some serious issues. Teach a general principle. So taking into account those symptoms, you say in a patient with chronic cough and weight loss, always consider tuberculosis. So this is how we teach them a general principle, and finally we can conclude. So thank you everyone. I'm done with this. So to summarize, we started with criticality and feasibility. So I'm sure all of you know what the boxes mean and where we have to put a skill and how we have to approach the way we teach that kind of skills. Then we also learnt about this 1-minute preceptor model to teach clinical skills, especially in the bedside. Thank you.
Yeah. So cooking and this next slide of mine reminds me of what happened to me yesterday night. When I went home yesterday and I was thinking of what to do to, teach you a psychomotor skill, my wife came out from the kitchen and she was asking me, what are you thinking? I told her, yeah, I have to do this Python's 4 method to teach them psychomotor skills. Then she asked me, okay, I will teach you. I'll give you a small example. And then I said, okay, fine. Then I went into the kitchen and she demonstrated of how to make a chapati. She deconstructed of how to make a chapati. And then there was a comprehension of how to make a chapati. And I was supposed to perform. By the time I got a certificate for my performance, and then I realized I made chapatis for the entire family. So from today, I decided I have to go home only after 9 in the night. Yeah. So, slide. Open Ola. So even the slide doesn't want to open. Next. Yeah. So this is how you teach psychomotor skills. This is called as Python's 4-step approach. And first is to demonstrate. Second is to deconstruct. Third is comprehension. Fourth is performance. So demonstrate is, if I am the trainer, I demonstrate what is supposed to be done. Okay. Next, deconstruct is trainer describes the steps of that particular skill and then demonstrates, right? Next, comprehension is learner describes the steps, whereas the trainer does it. Performance is learner describes the steps and then demonstrates it. So, this slide is clear? Yeah? So now, we are going to do a activity, right? Any one of you, I have my postgraduate, so Dr. Jashwant, please, can you come with a pair of gloves? So you have to teach him the skill of wearing a glove. So any surgeon, please don't look at the clinical aspect of it, but just in this context of teaching a psychomotor skill by the Python's 4-step approach. Can someone do it with him? Or Saiteja? Yeah, thank you. So first you will demonstrate, right? Then you will demonstrate by doing. Next, the learner will describe the steps. You will describe and he will demonstrate. Last is both together. Yeah. You want it this way?
So today I'm going to teach you a skill about how to wear a surgical gloves with sterile precautions. Okay. So there are some key steps in wearing these gloves. So first we have to see what is the size of the gloves, whether it fits to our size or not. Okay. So this is 7 number gloves. So we have to, there is some small slit is there. So we'll use this slit to open the gloves. So this is the second step. So you can keep it here or a sterile surface. So there is one glove for the left and one glove for the right hand. So with my right hand, I'll pick up the left hand gloves. I will insert my fingers of the left hand into this, and I will rotate my fingers, and I will push it. Okay. Then with my left hand, I will pick up the right side gloves. So with my fingers again I will insert, and I will rotate, and I will push it. So, understood?
Learner describes the steps, trainer does these steps. Trainer is you, learner is him. So he will tell you the steps. You have to demonstrate.
We'll open the glove with the, along the slit present on the cover. We will place.
He will be telling you, just do the steps.
We will place the glove on the sterile surface, open it, and with the right hand we will pick up the left glove. We will put our fingers inside and rotate the hand so that we'll. Then we will pick the other glove with the. We will pick the other glove with the left hand, and then insert the fingers of the right hand and rotate it so that we can wear the other glove also.
The next step is performance. The learner describes and then demonstrates.
We will open the glove along the slit, place it on a sterile surface. We use the right hand to hold the left hand glove. We will insert fingers and rotate the hand to wear the glove. Then we will pick the right hand glove with the left hand and insert the fingers and rotate it.
They are done? Yeah. Thank you, Sai. Thank you, Jashwant. So it is altogether demonstrate. I want it from you. From starting. Louder. Demonstrate, deconstruct, comprehension and performance. Right? So this is the Python's 4 method approach. So next, teaching technical skills. The model that is being described is the steps module. Okay. S stands for set the foundation, importance of the skill and the context of the skill should be told. Next, T stands for tutor demonstration without commentary. E is explanation by the tutor with repeated demonstration. P is practice under supervision by the learner, right? And then subsequent deliberate practice till the learner gets perfection, right? So clear about this slide? Clear about this slide? Yeah. So now, again I have my postgraduate. I have some things like the next thing that you have to do is, competency is to insert a IV cannula. Right? Yes, you have a doubt? That is only doing, no talking. He just shows how to do without any explanation. Next, he will again explain while doing. Yeah. Yeah. Yes, ma'am. Exactly. Without. So this, that is a competency that is there. So can I have any volunteer to do this method of training? Anyone? IV cannula? Non-medical, non-surgical. Respiratory medicine? Respiratory medicine, madam? Anyone? Psychiatrist. Forensic medicine. So anyone from forensic medicine? Sir, you're from forensic medicine? We'll not judge your skills, clinical skills. I just want you to demonstrate that. That's it.
Student, sir. You be the student, you will demonstrate.
Okay, done. So first step is to set the foundation, importance of the skill and context. So you have to tell the importance of what you are doing to the learner. This side, sir. Otherwise you can stand here.
Now we are making, now I'm going to teach you how to insert a cannula to the patient. So it is important to inject any IV drugs, or any emergency to blood transfusion or anything. We need to first insert a cannula into the patient. Now I'm going to teach you how to insert a cannula. First of all, we have to wear the gloves. After wearing the gloves, just we have to open the cannula. Open the cannula, and we have to hold the cannula in a position like this, and we have to stretch this one, and we have to put cannula like this here, and we have to remove the cap, and in the vein we have to keep it in an angle of 45 degrees like this, and we have to insert into the vein. Okay, into the vein, just we have to remove the needle, and we have to inject the drug.
So now the learner will practice under supervision, and the trainer will give a feedback. You have to give a feedback also.
Yeah, very good, well done, you're perfect. So we need more practice to get into the directly into the vein first attempt.
Thank you, Jashwant. Yeah, everyone clear with it? So this is for teaching technical skills. This is again a different model, that is the CISFR model. So now the real fun comes. Teaching communication skills, that we'll be doing by a Kalamazoo declaration. Okay, this declaration has the following 7 steps. That is, build a relation, open the discussion, gather information, understand the patient's perspective, share information, reach agreement on probable plans, and provide a closure. So for this, what we are going to do is again a group activity. So I will give a competency of explaining, that is taking consent and explaining the procedure for appendicectomy. Okay, so what we'll do is the red group will do it. Okay, the next 2 groups will, all the other groups have to observe. These 2 groups have to critique what went wrong. These 2 groups have to say what went well. Right? So clear about it? I'll give you 2 minutes, so please kindly decide who wants to be the patient, who wants to be the doctor, and the remaining as attenders. And you have to do a role play. Explaining and taking consent for emergency appendicectomy. Right? 2 minutes, please kindly decide. Yeah, so the red group is going to do a role play. Can we have a round of applause for them? Thank you. And please, if you don't mind, please carry your own chairs to the dais, please. Chair. All of you have to come. Huh? Patient will not come alone, he will come with attenders. So please, no, one attender never comes. When you say surgery, there are 100 people coming, so please. So who is the doctor, who is the patient? You are patient. Anesthetist becoming a patient. Okay, surgeon is the doctor, Right, okay. Please take your question, sir.
Language. English.
All of you are comfortable with Telugu? Yeah? Telugu? Yeah, fine, Telugu. Start.
I should explain patient attenders first. Attenders.
You have to build a relation first, open the discussion, gather information from the patient and patient attenders, then understand the patient's perspective for appendicectomy, then share information, whatever you want to do, what are the pros and cons, and then you are closed.
నమస్తే అండి.
సార్ మీరు ఇప్పుడు నా పక్కన కూర్చోండి సార్. డాక్టర్ దగ్గర అటెండర్. మీరందరూ డాక్టర్ పార్టీలో ఉన్నారు ఇప్పుడు.
నమస్తే.
నమస్తే
మీ
మేడం.
పేరు?
నా పేరు అనిల్ మేడం.
మీ పేరు?
నా పేరు అనిల్ మేడం.
ఏం చేస్తుంటారు?
నేను ప్రస్తుతానికి ఖాళీగానే ఉన్నాను.
సరే, ఎప్పటి నుంచి ఉంది? ఏంటి ఇబ్బంది? ఎందుకు వచ్చారు హాస్పిటల్కి?
పొట్టలో నొప్పి వస్తూ ఉంది మేడం.
ఎన్ని రోజుల నుంచి?
3 days నుంచి.
3 రోజుల నుంచి. దాని ముందు ఎప్పుడు రాలేదా?
ఎప్పుడు రాలేదు మేడం.
వామిటింగ్స్ ఏమైనా అవుతున్నాయా?
అవుతున్నాయి మేడం.
ఎన్ని రోజుల నుంచి?
అది కూడా 3 days నుంచి.
జ్వరము
వస్తుంది మేడం.
లూజ్ మోషన్స్ అలా ఏమైనా అవుతుందా?
లేదు మేడం.
3 రోజుల నుంచి ఏం చేస్తున్నారు రాకుండా?
రోజుల నుంచి అంటే 2 డాక్టర్ల దగ్గరికి వెళ్ళేసి మళ్ళీ మీ దగ్గరికి వచ్చాను మేడం.
బయట డాక్టర్ దగ్గరికి వెళ్ళేసి వచ్చారా? అప్పుడు మందులు వాడినప్పుడు తగ్గిందా మీకు?
తగ్గలేదు మేడం.
ఎక్కడన్నా బయట స్కాన్ చేసుకున్నారా?
లేదు మేడం.
ఎక్కడ అడ్మిట్ ఏం కాలేదు, డైరెక్ట్ ఇక్కడ తగ్గలేదని వచ్చారు. సరే, ఒక పని చేస్తాము. ఇప్పుడు మీకు ఒక స్కాన్ చేస్తాము. స్కాన్ చేసి లోపల మీకు ఏమి ఇబ్బంది ఉంది ఏంటి అనేది చూస్తాము. చూసేకి కొంచెం అపెండిక్స్ లాగా అనిపిస్తుంది. 24 గంటలు పేగంటారు అలా అనిపిస్తుంది. చూద్దాము. స్కాన్ చూసి బ్లడ్ రిపోర్ట్స్ పంపించి ఇవి చెప్తాము. ఓకేనా? ఇంకేమన్నా మీకు డౌట్స్, ఇబ్బంది ఏమన్నా ఉందా?
అంటే
ఏం లేదా?
అంత ఫ్రీగానే చేస్తారు కదా మేడం?
అన్నీ ఫ్రీగానే అండి. గవర్నమెంట్ హాస్పిటల్ కదా, ఫ్రీగానే చేస్తాం. సరేనా? ఓకే. సో ఐ హ్యావ్ గాట్ రిపోర్ట్స్. ఓకే. మీరేమవుతారండి పేషెంట్కి?
మా బ్రదర్.
ఓకే. నా పేరు డాక్టర్ జోష్న. సో వాళ్ళని చూస్తున్న సర్జన్ని. ఇప్పుడు స్కాన్ రిపోర్ట్స్ వచ్చాయి. సో 3 రోజుల నుంచి కడుపు నొప్పి కాబట్టి స్కాన్లో అపెండిక్స్ అనేసి ఇచ్చారు. సో ఫస్ట్ మేము బ్లడ్ రిపోర్ట్స్ చూస్తాము. బ్లడ్లో ఎంత ఇన్ఫెక్షన్ ఉంది ఏంటి అనేసి చూసి మోస్ట్లీ ఆపరేట్ చేయాలి అనుకుంటున్నాము. కానీ ఆపరేట్ చేయాలనుకుంటున్నాము. సో ఫస్ట్ రిపోర్ట్స్ అవన్నీ రానివ్వండి. ఇప్పుడైతే ఏమీ తినద్దు, తాగొద్దు. అడ్మిట్ చేస్తాం, వార్డులో అడ్మిట్ చేసి ఇవి చేస్తాము. ఓకేనా? ఇంకా
ఆపరేషన్ జరిగిన తర్వాత ఎన్ని రోజులు ఉండాలి మేడం హాస్పిటల్లో?
1 వారం ఉండాల్సి పడుతుంది. సరేనా? ఎక్కువ టెన్షన్ పడేకే ఏం కాదు, కానీ ఆపరేషన్కి తగ్గట్టు ఆపరేషన్ చేశాక మీకు వచ్చే రిస్క్స్ అవంతా కూడా చెప్తాము. అండి, ఒక్కొక్కసారి ఆపరేషన్ చేసి మీకు షుగర్, బీపీ ఏమన్నా ఉందా?
లేదు మేడం.
ఏం లేదు. సో ఒక్కొక్కసారి ఆపరేషన్ చేశాక ఆపరేషన్ సైట్ దగ్గర మీకు ఇన్ఫెక్షన్ అయ్యే ఛాన్సెస్ ఉండొచ్చు. ఒక్కొక్కసారి ఇప్పుడు 3 రోజుల నుంచి నొప్పి అంటున్నారు కాబట్టి స్కాన్లో ఏమంటారు మాస్గా ఏం చెప్పలేదు, కానీ ఓపెన్ చేశాక ఒకవేళ లోపల మీకు గడ్డగా ముద్దగా అయిపోయిందంటే అప్పుడు ఓన్లీ ఆపరేట్ చేయకుండా ఓన్లీ చీమ్ ఉంటే చీమ్ తీసేసి వస్తాము. మళ్ళీ 6 వారాల తర్వాత ఆపరేట్ చేస్తాం. అది మేము ఇప్పుడే చెప్పేకి లేదు. ఆపరేట్ చేశాక లోపల చూసి చెప్తాం. అది చెప్పేకి. ఇంకా ఒకవేళ ఎక్కువ ఇబ్బంది ఉంది, మీకు లోపల పగిలిపోయి ఎట్లా ఉంది అంటే అప్పుడు పెద్ద ఆపరేషన్ చేయాల్సి వస్తుంది. ఓకేనా? చేసి 1 వారం ఉండాల్సి పడుతుంది తర్వాత మీకండి.
ఆపరేషన్ లేకుండా ట్యాబ్లెట్స్లో తగ్గించడానికి కావాలి?
లేదండి, ఆల్రెడీ 3 days అయిపోయింది. స్కాన్లో కూడా రిపోర్ట్ పాజిటివ్ ఇచ్చారు. ఇంకా బ్లడ్లో కూడా ఇన్ఫెక్షన్ ఉంది కాబట్టి ఆపరేట్ అయితే చేయాలి.
ఓకే మేడం.
ఇంకేమి డౌట్స్ ఉన్నాయి?
బ్లడ్ ఏమైనా తెచ్చుకోవాలా మేడం?
ఏంటండి?
బ్లడ్ ఏమైనా తెచ్చుకోవాలా?
ప్రస్తుతానికి అవసరం లేదు, బాగానే ఉంది. ఒకవేళ అవసరం పడితే ఆపరేషన్ చేసిన తర్వాత మళ్ళీ బ్లడ్ రిపోర్ట్స్ చేస్తాం. ఒకవేళ అప్పుడు తక్కువ ఉంటే మేము అడుగుతాం. ఓకేనా? ఇంకెవరికన్నా మీ వాళ్ళు ఎవరన్నా వస్తారా?
ఇంకా మా క్లోజ్ రిలేటివ్ మేడం.
ప్రాణాపాయ స్థితి ఏమైనా ఉంటుందా మేడం?
ప్రాణాపాయ స్థితి అన్నట్టు కాదు, అదే ఆపరేట్ చేశాక లోపల ఎట్లుంది కండిషన్ చూడాలి. ఇప్పుడు ఆపరేట్ చేసి అయినా కూడా తర్వాత పోస్ట్ ఆపరేటివ్గా కూడా మానిటర్ చేయాలి. సో ఆ తర్వాత ఇప్పటికైతే ప్రస్తుతానికి ఏం లేదు. సో మీరు ఎక్కువ టెన్షన్ పడేట్లు అట్లని కాదు, పెద్ద ఆపరేషన్ కాదు, చిన్న ఆపరేషన్ కాదు.
ఎంతవరకు గ్యారంటీ?
ఏం గ్యారంటీ? ఏం గ్యారంటీ?
లోపల గడ్డ అది అని చెప్తున్నారు కదా.
చూడండి, నాకేం ఎక్స్రే కళ్ళు లేవండి. నేను స్కాన్ల ప్రకారంగా చెప్తున్నా. అంటే ఇప్పుడు 3 రోజులుగా నొప్పి ఉంది కాబట్టి మనం చెప్పలేము, అందుకే చెప్తున్నా. ఆపరేషన్ ఇప్పుడు స్కాన్లో ఒకటి ఇచ్చినా ఆపరేషన్ చేసేటప్పుడు టేబుల్ మీద వేరేగా ఉండొచ్చు. అందుకే ముందే చెప్తున్నా, ఒకవేళ మాస్గా కానీ ముద్దగా కానీ ఉంటే మేము చేయకుండా వస్తాం. అది మీకు ఓకేనా?
ఐసీయూలో పెడతారా మేడం ఆపరేషన్?
ఆపరేషన్ చేసిన తర్వాత పెడతాం, ఒక 2 రోజులు.
వద్దు మేడం ఐసీయూ నాకు.
ఎందుకండి?
భయం మేడం, నాకు ఐసీయూ అంటే భయం మేడం నాకు.
చూడండి, మీకు ఆపరేషన్ అప్లై చేసాం కాబట్టి మంచి క్లీన్ ఏరియాలో పెట్టాలి. సో మీరు వద్దన్నా కావాలన్నా అక్కడే పెడతాం.
సరే మేడం.
ఓకేనా అండి?
తప్పదు అంటే ఓకే మేడం. తప్పదు అంటే ఉంటాను మేడం ఐసీయూలో.
తప్పదండి, ఉండాలండి. ఇంకా
మొత్తం ఎన్ని రోజులు అడ్మిషన్లో ఉండాల్సి వస్తుంది?
మోస్ట్లీ ఒక 1 వీక్ ఉండాల్సి పడుతుంది. నేను మీకు మళ్ళీ చెప్తున్నాను, లోపల ఒకవేళ 3 డేస్ హిస్టరీ కాబట్టి మీకు ఒకవేళ మళ్ళీ అక్కడ ఆపరేట్ చేయలేని సిచ్యువేషన్లో ఊరికే ఒక ట్యూబ్ పెట్టేసి వస్తాం, మళ్ళీ 6 వారాల తర్వాత రిపీట్ చేస్తాం.
మళ్ళీ ఆ ట్యూబ్ ఎప్పుడు తీసేస్తారు? ఆ ట్యూబ్
3 రోజుల్లో అట్లా తీసేస్తాం, మళ్ళీ ఫుడ్ అలో చేశాక.
ఆ ట్యూబ్ వల్ల మళ్ళీ మనకి ఏమైనా నష్టాలు ఉంటాయి?
అట్లా ఏం లేదండి, ఏం రాదు, ఇబ్బంది ఏం లేదు. ఆపరేషన్ థియేటర్లో మేము చూసి అప్పుడు వచ్చి కూడా మీకు చెప్తాం చేస్తామా లేదా అని. ఓకేనా? ఇంకేమైనా డౌట్స్ ఉన్నాయండి మీకు? ఓకేనా ఆపరేషన్కి?
గుడ్, థ్యాంక్ యూ. So I'll give you 1 minute, fast 1 minute, just think about what points went well and what didn't go well. Yeah, please. Maybe once you are ready, I think you can start talking. Just get ready. I think the blue group is ready. So they want to talk about what went well.
Regarding that skit, the positive findings were, first thing, the attenders were provided with the seating, they have provided the chairs, and proper counseling was done, and doctor's history taking was good, and the explanation was also proper, and she introduced to the attenders as a doctor that I am so-and-so surgeon and all, and good counseling for the patient. Even the patient had good communication skills. He was his cross questions were pretty good, and even the attenders were asking the questions properly, and finally the attenders, all the questions were answered, and even the final ICU counseling was also done, but sepsis was also done. Sepsis counseling was also done. Thank you.
They are given space for them to sit, and they are in a comfortable position. And it's an open discussion with the patients, so they can ask their questions, anything, other complications, everything been it's like open discussion. Sir, everyone made comfortable during the discussion, for the patient and the attenders.
So what didn't go well?
She has introduced as a doctor to the attender, but not to the patient, sir. She just told namaste. See, please.
Introduction, sir.
Mala. Andike bhayam nito maatladante. She told it is like looking like appendix. Because appendix will be present in all people. She should have told it looking like some infection in the appendix. Third thing, she did not use the type of surgery done, open or laparoscopy or any conversion. She not talk about the types of options available because we should inform the patients what are the available options. That's all, sir. And she told, otherwise good, sir.
So you want to add something?
Convincing way, sir. Not so like it has to be. Yeah, yes.
So anyone wants to add, sir? You want to add? No? Yeah, I think it was an overall good performance. And so, yeah. Madam? Anesthesia was not told. Yeah. So, documentation, yeah. So, consent and documentation was not taken. Yeah. Doctor was little arrogant. Okay, fine. Maybe because the patients were very calm, doctor was arrogant. Yeah. So, this is again the Atcom module. So, if you have to develop, yeah. So, if you have to develop a skill from a competency, like what is the steps that you have to follow? First, review the competency. Determine the level of competency or proficiency that is required. So when you think about this step, it is either a perform, shows how, or it should be a knows how. Right. So after you determine the level, then plan for a session. Okay. With stepwise progression to achievement of the level of competency. Next, determine the method of assessment of skills, and if required, give it a certified. So because we have certifiable skills also here. So planning a skill session. So this is how the planning for a skill should occur. Define the objectives, derive a lesson plan. Once you derive a lesson plan, get the preparatory sessions done. Next, plan for an assessment and create the resources. So this is a planning for a skill session. So, whenever you're talking about or giving a competency skill as a competency, this is how you have to divide it. That is, name of the group, felicitator, supervisor or the faculty, the parameter and the description. That is name of the lesson, number of learners, that is how many people you want to allot to that particular competency. Next, primary teaching method that is to be chosen. Breakup of the session, that is first step what you want to do, the second step what you want to do, the third step what you have to do. Because if you do the third step the first, the skill is going to be a waste. Okay. So you have to categorically, stepwise, you have to give it a step. Right. What are the teaching aids that are required? Infrastructure that is required. Student preparation before he comes to the skill station. Assessment method to be chosen and other comments. So this is how you have to give a document after you do a skill station. So this is a small example of a session that was planned, that is for recording blood pressure. Okay. So number of learners could be 10, 15, right? Objectives of the session is, what could be the objective of the session is the learner should be able to record the blood pressure, right? Primary teaching method could be a DOPS session, right? Anything that could be added for a primary teaching method, or DOPS, or you can show them a video, right? Yeah. So, breakup of the session is first he has to counsel the patient and take the consent from the patient. Check the BP apparatus and the stethoscope. Ensure appropriate position of the patient, right? Expose the arm and support it at the level of the heart. Palpate the brachial artery in the cubital fossa. Wrap the cuff smoothly. This is all the steps that follow each other, right? So the teaching aids that require is a BP apparatus and a stethoscope. Infrastructure that is required is a volunteer or a mannequin. Handouts, checklist, bed or a couch. This is what he has to come prepared with. So even before you give the skill, you have to tell the student what you have to prepare and come. If you're not going to give that particular document, you can't expect him to read and come. Yeah? Right. So assessment method would be a OSCE type station and other comments. So this is how you have to do a skill station, right? So skill lab, coming to setting up a skill lab. What all should a skill lab have? Okay, right. One, it should be patient safe. It should be a safe environment for practice, okay? And it should also give a environment for re-practice, right? If you are failing in the first time, you have to re-practice and re-practice, okay? It should be deconstruction of a skill, technical skills and non-technical skills. You should be able to give feedbacks to the learners, and the learners should be able to do a repeated practice. So in skill labs, what all do we have is plastic models, mannequin type stimulators, a high fidelity or a low fidelity, right? Screen-based virtual reality stimulators, animal models or animal tissues that can be used, human cadavers, and stimulated or standardized patients. So these are various things that we can use in a skill lab. So these are examples of plastic models. One is for a urinary catheterization or breast examination, suturing, or different suturing techniques that can be used, right? So now again, we'll have a group activity. Yeah, I think Dr. Lokesh will take over from here.
Till now, you have learned about how to form a skill lab, and we are going to do activity for competencies. So each group will get one competency. 5 competencies are there. You have to do set up a skill lab session according to this one, according to this session plan. Okay. The chart is there in the 50th page of your book. Okay. And there are certifiable skills given in the book. It is there on the 84th page, page number 84. There are some certifiable for each department. They are given certifiable skills. So I have made some 5 for each group 1. If you want to take anything from the certifiable skill, you can take it. If you don't like the competency, and you can write the session plan according to that. So you'll have 10 minutes for writing. This is the group 1. So group 1 will take the task 1. Group 2, task 2. These are there in the curriculum, UG curriculum, whatever you have downloaded. In that it is there. You can take down that OG 3517 number, and you can build on it. Okay. Yeah. Suturing 14.4. And task 3, group 3. So task 4. And task 5. So each group will present other groups can add the points. You can write it there. You can write on the chart. Yeah, write on the charts. That is for your reference. What are the headings? Write on the chart, and one of you can present. Huh? See, which method you are going to take it? Objectives, I have given it. That from that competency you have to get the objectives. Then you have to choose the method, teaching method. In the teaching method, where you are going to do it, whether in the simulated environment or in the real patient. Yeah, you can do it. Mannequins are there. Skill labs, mannequins are there. See how BP. See how these steps are breaked. You have to do it. This is a skill. For every skill, there are different things. So whatever the competencies which are related to that in phase 1, phase 2, phase 3, all those can be linked. It can make a module and ask the other teachers also to come and demonstrate their part, like a linker method or like a sharing session, or you can do a nesting. You can only tell their part also. Start writing. One of you start writing, others can give you the inputs. We are running out of time. These competencies are there in your curriculum book, the phase 3 curriculum book. You can see what type of competency it is. Shows how. Some of them are there in the ASCII stations. That's why I skipped.
Okay. Dressing?
Dressing also you can take. In these skills, whatever you want, you take it if you don't like that. Skill lab is used. Skill lab is used. What method you are using? In the skill lab, you are using the skill lab. But what method you are going to use to teach? Python's method. Python's. So there is a DYAP. DYAP is the broad term. Python's 4 method.
multiple attempts, no discomfort.
proper teaching.
Multiple attendance, no discomfort to patients.
అది యాక్చువల్గా ఇది లేదు దాంట్లో, ఇది లేదు.
డిసడ్వాంటేజెస్
ఇది లేదు. అడ్వాంటేజ్ అండ్ డిసడ్వాంటేజ్ లేదు. You can remove that advantage and disadvantage. Okay, other things you do it. కమ్యూనికేషన్ అన్నీ వస్తుంది దాంట్లో, అదే కదా టీమ్ వర్క్, ఎవ్రీథింగ్ విల్ కమ్ ఇన్ దట్. కమ్యూనికేషన్, యాటిట్యూడ్, స్కిల్. What undergraduate is going to do, sir, in the team? The team is there. You have to assign. అది ఆల్రెడీ ఎక్కడ ఉందనుకుంటాను, ఆస్కీ స్టేషన్లో ఉంది. దట్స్ వై ఐ స్కిప్డ్ ఇట్. యాక్చువల్లీ దే ఆర్ గివెన్ సమ్ మాడ్యూల్స్, 5 మాడ్యూల్స్. దాంట్లో 3 పెట్టి 2 తీసేసాను, వేరే చోట చేస్తున్నారని. నీకు సర్జరీ కదా వచ్చింది
సార్? టెన్షన్ ఏమోతారెక్స్ అది వచ్చింది. కష్టపడేది
దాంట్లో ఒకటి తీసుకో, ఫ్లయల్ సెట్స్ కానీ టెన్షన్ ఏమోతారు కానీ ఏదో ఒకటి తీసుకో. ఓకే, వాట్ ఎవర్ యూ వాంట్.
చెప్పేసి
అది అవసరం లేదు. అడ్వాంటేజ్ అంత అవసరం లేదు. అడ్వాంటేజ్ డిసడ్వాంటేజ్ అవసరం లేదు. బ్రేకప్ ఆబ్జెక్టివ్స్ అదే అదే స్టెప్స్ రాయాల. హౌ యు ఆర్ గోయింగ్ టు టీచ్ దెమ్ స్టెప్ వైజ్. వాట్ ఆర్ ద మెటీరియల్స్ రిక్వైర్డ్. ఇక్కడ ఉంది కమ్యూనికేషన్. ఇక్కడ వచ్చేస్తా. See, if you are taking IV line,
able to insert IV line curriculum, IV line find చేస్తాను.
any group is ready, we will start. Okay, sir.
They have done. They are done.
2 groups done, sir.
2 groups are done.
Repeat required.
Repeat practice. And then we can get feedback.
Videos. Visual aids. Audio visual aids. Infrastructure required.
Required prayer reading.
Okay, I think everyone is ready. Yours is a difficult one. Huh? Simulation you can use it. High fidelity mannequins you can use it.
Next other comments.
The skill lab. There are high fidelity mannequins where you can show pneumothorax. పెట్టంగానే గస్ ఆఫ్ ఎయిర్ వస్తుంది. పేషెంట్ స్టెత్ పెట్టింటే బ్రెత్ సెన్స్ ఆబ్సెంట్ ఉంటాయి, తర్వాత బ్రెత్ సెన్స్ వస్తాయి. హై ఫిడలిటీ మ్యానిక్యూన్స్ అండి. హై ఫిడలిటీ మ్యానిక్యూన్స్ పెట్టారు కదా.
హై ఫిడలిటీ మ్యానిక్యూన్ అంటే మీనింగ్ ఏంటి సార్?
ఫిడలిటీ అంటే దాన్ని ఎలా వాడచ్చు, మనిషిలాగా రియల్ మనిషిలాగా
అంటే అన్ని సినారియోస్ దాంట్లోనే ఉంటాయి.
ఓ మీరు ఎప్పుడైనా చూసారా?
మేము వెళ్ళాం చెన్నైకి.
చెన్నై పోతే అప్పుడు ఇక్కడ ఉన్నాయి.
సో see these things.
అలాంటిది ఎగ్జిస్ట్ అవుతుందని నాకు తెలియదు.
సెకండ్ వన్
అంటే ఒక మ్యానిక్యూన్స్ ఏముండవు.
Okay. First group, we'll start with first group. Someone from the first group should present this. Other groups can add whatever points they have missed. They can add other points to the group. Randi madam. Okay.
So name of the lesson is urinary catheterization. So number of learners would be 10 to 15 students for the session. So objective of the session is, at the end of the session, students should be able to learn and perform Foley's catheterization independently in a simulated environment or in the skills lab. So the primary teaching aid, what we would require will be the skill lab. So we will be using Payton's four-step method. So next is how do we break up the session. So first is demonstration by the trainer, followed by a demonstration and performance by the trainer, and demonstration by the learners and performed by the trainer, and lastly demonstrate and perform by the learner itself. So infrastructure, what we require is the skill lab. So student preparation would be required, yes, and assessment would be DOP session, OSPE, and Mini-CEX can be applied.
DOPs can be used. Other groups, anything you want to add? In the breakup session, she said demonstration and steps of the Payton's method. But what are the things you are going to provide and show to the learner? What are the requirements? You need a catheter, sterile environment. Those are steps you have to. You can include so many, not only 5 steps, you can include 20 steps also you can include. Okay, it's not restricted. You can use how many steps you want, you can use it. Depends on the knowledge of the learner who is going to come to the session. Okay, so if some, yeah, backup session. Infrastructure is required, but breakup session, what are the things in the order? First, a mannequin is given to you. A low fidelity mannequin we are using here for catheterization. So mannequin is given. First, you have to demonstrate the steps, how to sterile the part what you are using, then how to take the gloves, then how to take the catheter, requirement of sterile water for inflation of the bulb. All those things, steps should come. Okay. In the breakup session it will come. So infrastructure, skill lab you are using, mannequin, and the mannequin you are using it. Okay, low fidelity mannequin it is. And student preparation, yes, you are written yes. What are the preparation that they require?
Just to read about what is catheterization.
They should know the anatomy of the urogenital tract to catheterize. Yeah. So basic is anatomy must required. That's phase 1, phase 2, phase 3, whatever things you are using, they will be having competencies. Those competencies can be ask them to read and come. They might have read, they might have forget. You should ask them to read and come so that we can teach our part, the final year part. Okay. So assessment method. Anything you want to add? DOPS. This is direct observation of procedural skills. That is the common method we'll use for any psychomotor skill. So if you want to teach them other cognitive things in this, you can use other methods also, like OSPE you can use, Mini-CEX you can use. Okay. So any inputs? Okay. Thank you and congratulations to the group 1. Group 2. Group wise will go.
Good afternoon. So for our session plan, so we got SU 14.4, that is demonstrate technique of asepsis, suturing in a simulated environment. Number of learners we have taken is 5. Our specific learning objectives are, should be able to demonstrate proper aseptic techniques, should know the instruments and suture materials required, demonstrate proper suturing techniques correctly, should know the proper disposable of instruments, sharps correctly. And primary teaching method is in the skills lab. We do a DOOP session, demonstrate, observe, assist, perform. Then we can do a video session also for giving the orientation. So advantages are, it's safe as we are doing it in a simulated environment. Coming to the breakup, initially we'll do a video session and we'll orient the learners. Then we'll take them inside the skills lab. We demonstrate the procedure of asepsis and suturing techniques. Then we can ask the learners to deconstruct, and as we are doing, we can ask them to, we'll deconstruct and we'll say, then we can ask them to perform, and then we can ask them to repeat procedure if they're not, if required, and then we can take the feedback. And then we can teach them how to dispose the instruments and sharps correctly. And the teaching aids are, you can use audio-visual aids here. And then we require silicone modules and the suturing equipment and suture materials. Student preparation, we'll tell them to reach the basic concepts of tissues, anatomy, and we'll ask them to teach the basic concepts of asepsis, suturing techniques, suture materials in the standard Valiant level textbook. Assessment method, we can use DOPS and OSPE here.
Yeah, for the primary teaching method, you said DOIP and videos. Any other method can be used? Any other method can be used to teach primary teaching method? Is it DOPS and video? Any other teaching method?
And small group. Small group teaching. Lecturers and
objectives, suture materials, suture materials, technique, all those things you can show.
So lecture we can take. So assessment methods also there is OSPE and DOPS. Any other method? Any other method by which we can assess?
even give theoretical questions and MCQs also, because MCQs and theoretical. MPQs. Thank you.
Our topic is provide intranatal care and conduct normal delivery. It belongs to OG 13.4 and 13.3. Number of learners are around 10, and the time allotted is 2 hours. And the objectives of the session are learners should know, by the end of the session, the students should know about the steps of labor, should be able to demonstrate normal vaginal delivery in a mannequin, and should know the complications during labor, and they should also know the intranatal care, the risk factors, and how to check previous records and monitoring during labor. The primary teaching methods is DYP, AV8s, and skill lab, using mannequins in a skill lab. And faculty preparation is to collect resources, AV8s, and prepare handouts. Break of the session. First 20 minutes we'll show AV8s. Next 10 minutes we'll demonstrate the normal delivery, normal steps of delivery, steps of labor. And next 20 minutes we'll deconstruct it. Next 30 minutes we'll do a comprehension, and then we ask them to perform for 20 minutes. And the last 10 minutes feedback, and next 10 minutes will be conclusion. And teaching aids required are AV8s and handouts. AV8s, audiovisual aids. And
what is the skill that you're teaching?
Skill is demonstration of normal delivery.
So normal delivery, what is the most important?
We need a fetal pelvis and fetal head. That's in mannequin.
You have to specifically say which mannequin you require. If you don't have it, I have to buy it now, depending on your inputs. I hope the OG department is aware. We have a pelvis, baby, everything.
Yes.
Nobody is using it, unfortunately. So that is why I want you to spell it out.
Okay.
No offense meant to any department. I'm generally making this statement. So please, AV8 means, what do you want AV8? You have to tell me. What are you going to show?
We'll demonstrate animated videos of normal delivery.
So where will you source it?
From the YouTube or
Okay.
from.
So you have a lot of websites on YouTube. You have to choose a video that is most appropriate. So subject experts may look at it and decide. Okay. So there is one which is common. I will let you know the name. I'll share it at the end of the session. That it is prepared. It is called geekymedics.com. Okay, Geeky Medics, Geeky medics.com. Okay, it is a group of house surgeons in UK who have set up this website, and they have got excellent OSCE skill videos for almost all skills, including history taking, clinical examination, procedural skills, normal delivery, starting an IV line. So geekymedics.com. Only thing is, you have to hack it to download it. It's not downloadable as it is, but if you have YouTube downloader, you can download it, and it's a fantastic resource that you can use it to show students. Okay, so you have to be very clear as to AV8 means what are you going to show. You're going to show a video of a normal delivery, not on a patient.
Yes.
It is how you have to do the steps in a mannequin. That video only you should show first. Then you use the actual mannequin and teach the steps, like you said, the 4 or 5 steps that Siddharth has outlined. Yes, what else?
Infrastructure required is we need a fetal pelvis, we need a pelvis and a fetal head and baby, and it is done in skill lab. And student preparation, we'll ask them to read intrapartum care, what are the steps of normal delivery from Datta. It's a OBG book, and we ask them to read about complications during labor. And assessment is by DOPS, OSCE and short essay questions.
What? Assessment by?
DOPS.
What is DOPS, man? What is DOPS?
Teach.
Is it a teaching method? We are not talking about DOAP. What are you talking about? DOAP or DOPS?
DOPS.
What is DOPS?
Direct observation of procedures.
Yeah, direct observation of procedural skills is essentially on the patient, not on the mannequin. So don't use that. OSCE is a method of assessment for a skill station. So DOPS is actually on the patient that you can use for interns or postgraduate assessment, not for undergraduates. Okay? Great. Thank you. Anything else?
You can add other objectives also, like what are the instrument delivery. They will use instruments. Sometimes they will use vacuum. So that also you can add, assisting a normal delivery. Okay. Next, group 4. Congratulations to the group 3. Did well.
So, name of the lesson, it is pediatric IV cannulation. It comes under PE 24.16. So, number of learners 20. Objectives, at the end of the session, students should be able to recognize the vein which is compatible. They should be able to use correct size of the IV cannula. They should be able to insert the IV cannula correctly. They should be able to recognize the signs of both successful and failed cannulation. They should be able to manage the complications. Primary teaching method, it's a DOP session. Breakup sessions, step 1, patient preparation. They have to explain the procedure and they have to obtain the consent from the patient. Step 2, have to conduct in an aseptic precaution, how to take aseptic precautions and all. Step 3, cannula insertion. Step 4, confirmation in securing the cannula. Step 5, the complications management. Teaching aids used are mannequins in skill lab and audio visual aids. Infrastructure required, IV cannulation mannequins, tourniquet and different sizes of IV cannulas, antiseptic swabs, adhesive dressings and saline syringes. Student preparation is required. They have to prepare they have to know the anatomy of different veins. They have to read and come, sir.
Preparatory
about,
material.
Preparation.
They should
have
know
to
about the different sizes of the
different
cannulas.
sizes of the cannula. And
IV set, IV fluids. Okay.
what are the IV medications and all. So assessment method, OSCE. And this.
OSCE. If you are using a mannequin in the simulated environment, you can use dose. This one. OSCE. Okay. On the patient, you can use dopes.
Yes. Not for assessment.
Not for assessment.
You don't assess on patients.
Okay.
All these things ideally to be assessed on the mannequin, and you can't be saying marking and the patient you will be puncturing. Ideally, it should be done only in the skill lab, not on actual patients. That is when they become interns and PGs, that will be DOPS.
Okay. Thank you. Sure. Congratulations, Group 4. And the most difficult. Huh? No, you have here we are testing a team member. He is acting like a team member. The learner is acting like a team member.
And ours also is same, almost same as Group 4. Only thing is, it's a team activity.
It's an emergency setup, man.
In a trauma patients, we are dealing with securing IV cannula and catheterization, intubation, and sprintage. So we wrote only
PG, MCH, trauma surgery level. Poor guy, you should have given an MBBS competency. Doesn't matter.
So it's almost the skill is almost same as Group 4, but since it is a team activity, so the objectives are each member in the team should act in coordination, and each member in the team should know what they are doing, what they perform, whether they are putting IV cannula or intubation, and
this is actually for the interns. This one.
And which one to be done as an emergency, so they should know as a part of objective. So the method is same. It's a direct observation assessment DOAP, and breakup is that initially the team formation should be done for each activity, for each performance. So we need a different things for each activity for IV cannula, catheterization, intubation, and sprintage. So for IV cannula, we prepared the breakup. I think it's almost same as what Group 4 has been discussed. So the teaching methods are you should get the intubation set for different type of patients, for children, for females, for adults, for old people, and different IV cannulas, and catheterization, different sizes of catheterization, and sprintage, all the POP sets.
Actually, this one I have given for a simulation environment. If there is an emergency patient coming into the casualty, if you are creating a situation like emergency in the simulation, we have to assign roles for the team members. Intern or a student will be a team member. If he is a student, he will be observing. If he is an intern, he will be assisting one of the procedure. Either one of this, either cannulation or ambu resuscitation, or he will be doing splinting. Anyone skill you can assign them. So here he needs a communication with other team members. He should coordinate with other team members. Though you are going to check attitude, communication, and skill, everything on this one.
So it's a fantastic scenario for a intern, but mostly used in a postgraduate teaching and assessment. So it can be a scenario where you think that not only a surgeon, an anesthetist may be involved, an orthopedic surgeon will be involved. So it may not be PGs from different departments, or like Lokesh said, we'll assume that an intern or a final year student is observing, or an intern is actually part of the team. So you can individually assess the intern only for the skill that he or she has been assigned. That is like IV cannula means use your checklist for assessment or for teaching. But here more important for teaching in this session will be the team. How to be a part of the team should be the teaching objective will be that. If you look at it at a higher level, how you should, the team assigns, one person becomes a leader, how you have to follow the leader's instructions irrespective of what you think otherwise. So how this student falls into the team, plays the team role and achieves whatever has to be achieved is what you should assess. So it is a little higher level of planning, and I'm very happy Lokesh gave this scenario, because we always try to teach in silos separately one skill, but put together in a team, how each member is able to do it is also one way of assessing. So this is something he's taken to a higher plane, and I'm very happy he got this scenario in mind. But remember that as an intern, they are supposed to know at least three of these skills. One is IV cannula, they should know catheterization, they should also know splintage of a fracture. So these three skills you're actually teaching and assessing a primary care physician. Maybe intubation and the team role and all will be at a consultant level or a third year PG level. So again, you should think that how you're going to train the student for the individual skills so that they fit into a team during a mass casualty or whatever it is. So I think very well done. I know it is a little more at a higher level than the usual, but nicely planned. Thank you.
Thank you, madam. I shared the module, that skill module in the group. You can see there are modules for the, I think 3 are there in those modules. You can see how you are done. Thank you.
Yeah, so now it's afternoon. Good afternoon. So I'll be taking the next topic of assessment in CBME, and I'll be joined with Dr. Dinesh to tell you about different forms of assessment. Yeah. So the objectives of this session are to understand the assessment principles as relevant to CBME, describe various assessment methods like OSI and OSPE, explain the role of feedback in assessment of CBME. So there are 3 basic terms that we have to understand. One is a summative, formative, and a internal assessment. Okay, right. So what is a summative assessment? What is a summative assessment? Any takes? So you are assessing after at the last. Okay, so that is something called as summative assessment. Example is the university examinations that most of this, all the students write. A formative assessment, what is a formative assessment? It could be an internal, yes, but the ideal thing of formative assessment is it is a repeated process. Okay, you assess the student, give feedback, again he will do it till he attains the perfection. Okay, so that is a formative assessment. Internal assessment could be both summative or formative. CBME has been defined as an outcome-based approach to design, implement, assessment, and evaluation of a medical education program using an organizing framework of competencies. Okay, it mandates greater emphasis on setting up an ongoing and a longitudinal assessment so that the teachers can identify the stage of the learner and decide whether they need further or different learning opportunities. So the basic concept of CBME is not like the regular assessment methods. What CBME assessment tells you is you assess the student on a regular basis. Okay, right. So you know where the student is actually lacking. You give him a feedback, and that learner again tries to learn or again performs. Right. So you know how he is progressing, and even the student also knows how he is progressing and where you have to interfere so that he has to get better day by day. So how does assessment differ in CBME than the regular things? The conventional curricula is a fragmented, whereas the CBME is integrated. It is mostly summative, whereas it is mostly formative. It is norm referenced, whereas this is the criterion referenced. So, as I've already told you, the principles of assessment in CBME is, it is a daily process. And it is held at regular intervals. Okay? So, it gives both feedback to the learner and also to the teacher on how you have to improve teaching, and for the learner, how he has to improve learning, right? So what are the different methods of assessment? Written tests, practicals, clinical skill examination, objective examination, oral viva OC, theses, and projects. These are some of the examples of how you can assess. And the main important thing is assessment methods are always in parallel to the competencies that are given. So if you're talking in assessment methods as per the competencies, now we have the, what is this pyramid? Name of this pyramid? Is the Miller's pyramid, yes. So I think slowly into that sleepy mode, yeah. So this is NOS. NOS is knowledge tested by written examinations. NOS, how is application of knowledge tested by clinical problem solving. Shows how is OSPE, case presentations, and DOES is a daily patient care. So this is how we assess according to the Miller's pyramid. So this is again a summative assessment method, and it keeps on changing with time and date and with the universities. Okay, but the NMC says 50% combined in theory and practical, not less. That is, he should have 50, but when practical and theory, it is 40%, right? So I think the next talk, Dinesh will take over to tell you different methods of assessment, right?
Thank you, sir. So good morning, everyone. So now I will be continuing the next session of the assessment. So first I will say how we are going to align our assessment with the competencies. Next I will be moving on what are all the various assessment methods which you can plan in CBME curriculum, and how actually you can assess an individual based on a single component or it is due to multiple components. And finally, I am going to demonstrate a assessment method that is mini clinical evaluation exercise, that is Mini-CEX, with a role play. So this will be the overview of my presentation. So this is one of the competencies which they have taken from the pathology. So the competency is identify the etiology of meningitis based on the given CSF parameters. So this is a competency, and it falls under which domain? So you should know etiology, so it is a knowledge domain, and also you should be able to say what exactly based on the CSF parameters it will come under, shows how. So this will be the level, and coming to core competency or not, yes, it is a core competency. So now we need to know what are the various assessment methods which you can plan for this competency. So first thing is, we all know we will derive the specific learning objectives, and we will attach the teaching learning methods, and finally we have the assessment methods. So it is already given in the curriculum. It's just a recap what has happened in the BCME itself. So the first specific learning objective is, at the end of the session, the phase 2 student must be able to enumerate the most common causes of meningitis correctly. So here they are going to judge on the knowledge. So you can frame a short note, or a part of a structured essay also can be made. So they have made like enumerate the 5 causes of meningitis based on the prevalence in India. So it should be complete. So previously there used to be called enumerate the 5 causes of meningitis in general. But here you need to have a specificities and a proper blueprinting needs to be done before you are going to frame a MCQs or any questions. So that is important thing which you need to understand when compared to the traditional curriculum. So here you can plan in even in MCQs also. And the second thing is same. So the student must be able to enumerate the components of CSF analysis correctly. So again it will fall under the knowledge domain. We can use a short note or a part of a structured essay, or we can have an extended multiple choice questions or true or false statements. So which will fall under again the knowledge domain. The third one, student must be able to describe the CSH features for a given etiology of meningitis correctly, and this also comes under the knowledge domain. You can ask as a viva voce also. But the last thing which is important, he should be able to identify the etiology of meningitis correctly from a given set of CSF parameters. Here both the knowledge domain is there and also how he is going to interpret the results of the CSF analysis in a given patient. So this you can plan a skill station by keeping an OSPE. So likewise, you can have the assessment methods for each competency by deriving the specific learning objectives in our all departments. So this is the basic principle how we are going to add our assessment methods to the competencies. So while having the assessment methods, this is just a sample assessment methods. So Miller's pyramid, as just Sar was speaking about. So if you go from nose, it ends up to does. So in the nose and knows how, we frequently test the cognitive domain or knowledge domain. So we'll ask MCQs, extended matching, or short answer, long answer, or viva voce. And if you go to the shows how component, so here OSCE, standardized patient, and simulation models you can take. And the finally does component, which I am going to talk Mini-CEX in detail. DOPS, this is direct observation of procedural skills. 360-degree evaluation, where a trainee will be assessed in 360-degree, not only from the faculty, co-trainee, ward staff, administration, friends, family. Throughout the 360 degrees, we can able to assess how a trainee is going to perform. So that is called 360-degree evaluation. And the chart simulated recall. By showing a chart, a critical case can be analyzed and ask him to recall whether the same case, whether he has taken in the past or not. So that is also one of the important thing. And the portfolios with reflection, I will talk when I am talking about the logbook. And the last important thing is workplace-based assessment. So what are all the various tools which you have in the workplace-based assessment, we will see. Before going to that, these are all various methods, assessment methods which are available in our curriculum. We all can go through that. So phase 1, so preclinical, paraclinical, it is called previously, but now we cannot call like that. We can call phase 1 and phase 2. And phase 3, part 1 and part 2. So these are all the various methods. For example, for preclinical phase 1, we have phase 2, we have lab-based assessment, viva, logbook, record book, and remaining things. And for phase 3, part 1 and part 2, we have case presentations, direct observation, OSCE, DOPS, record book verification, seminar presentations, etc. So these are all the various methods which are actually available. So now coming to the point, how we are going to give a assessment to a trainee. Is it a single method which will adopt, like giving 50 or 60 marks out of 100, or something else more than that which you need to understand? Can anyone tell me? So is it based on a single number which you are going to assess a trainee, or as we need to improvise our assessment according to CBME curriculum? Anyone, sir? So before going to that question, I will just elaborate on what are all the various assessment tools which you can practice in the workplace. So the first thing is documentation of work. So you can have a logbook or clinical encounter cards you can use. Direct observation you can do by mini clinical evaluation exercise, DOPS, acute critical assessment tool, clinical work sampling, discussion on individual cases by case-based discussions you can do. Feedback on the performance can be given by patient satisfaction questionnaire, and also we have assessment of knowledge and skills by OSCEs and MCQs, and record keeping by portfolios. So these are all the various assessment methods which you can use our workplace. So the question which I am asking, so when you are going to inform your trainee regarding an assessment, it is not just a number which you are going to assess. Rather than you should have more amount of word on a scale like satisfactory, below satisfactory or superior, or you can give a narrative of what and all he has done. So he started with a good open-ended questions and he has completed the interview well. So a mixture of all these things, permutations and combinations can be practiced before you are going to give a assessment to a trainee, which definitely have an effective output when he deals with the patients. So we cannot judge based on a number itself. And second thing is, there is no single method correctly used for assessment of skills. You can use multiple methods from the assessment toolbox which I have showed, so that we can complement and compensate. But we should not forget the basic principle for the assessment is, you directly observe through a standardized procedure, keeping a separate global rating scales, and give a proper focused feedback on the skill which has been performed is the basic principle which you need to keep in mind before you are going to address the trainee. So competency is difficult to assess using only objective tools. I already told narratives carry more weight than number. Skill assessment should be criterion based, but it is not a norm based which was done previously. And you cannot ignore the assessment of knowledge particular to that skill. For example, if you are going to wound suturing or you are dressing a wound, so the basic step is we need to wear the gloves. That is a knowledge related to that skill. We cannot forget that. So judging the knowledge which is related to the skill which a trainee is going to perform. So these are certain basic principles which you need to follow, and what are the various assessment methods I have covered, and how we are going to really attach our assessment methods to the competency. Now I will demonstrate one of the assessment method, that is Mini-CEX, Mini Clinical Evaluation Exercise. So here it is a formative assessment tool designed to provide feedback on skills essential to good medical care by observing a good clinical encounter. In simple words, a trainee will be observed by a faculty through a brief period, following which a feedback will be given, that is positive interaction will be done with the trainee and the procedure will be completed. So this is called Mini-CEX. Why it is called mini is, it is short duration, that is 10 to 20 minutes snapshot of doctor-patient interaction. That's why it is called as a Mini-CEX. So already I shared the pro forma with all of you. So what are the various components of Mini-CEX you can go through. So first will be the evaluator, then the resident you can keep as 1, 2, 3 or which year they are having, and what is a problem you can document, and setting. You can do this in multiple settings, OPD, IPD, emergency, or wherever you are going to assess the skill, you can do in a variety of settings. And complexity of the case, whether it is a low, medium or high, you can able to see. And you can also focus on specific skills properly, like you can focus on interviewing skills, diagnosis, therapy and counseling. You can able to focus on a particular skill, not entire thing, because there is only short period of time. And if you see the content, medical interviewing skills, all these things are rated from unsatisfactory 1 to 3, satisfactory is 4 to 6, and 7 to 9 is superior. So physical examination skills, professionalistic skills, judgment, counseling skills, organization efficiency, and overall clinical performance or competence you can able to score. And at last you have the observing minutes and feedback minutes. So 10 to 15 minutes initially you will have an observation, and followed by that last 2 to 3 minutes, or you can keep it as 5 minutes for the feedback. And evaluator satisfaction with the Mini-CEX also we need to rate. And the resident satisfaction with the Mini-CEX also we need to rate, and we should show everything to the trainee and get the signature and evaluator signature. So this is the basic pro forma of Mini-CEX. So this should be performed in 6 to 8 encounters with the same. For example, if you are assessing a skill, you need to perform the same with 6 to 8 encounters with a different faculty, so that each time what is the problem newly arised, the trainee can learn, so that a high quality of care can be given to the patients. So that's what was written here. It is designed to assess the clinical skills, attitude and behavior of the students, essentially to provide a high quality care, and it always lies in the high level of the Miller's pyramid, that is DOES component.
So this is called Mini-CEX. So when you think about Mini-CEX, we normally confuse with the short case discussions. So in the short case discussions also, we mainly focus with the brief history and clinical examination. But how it is different from a short case discussion? So what happens in Mini-CEX is, we can do in a variety of places, but short case, we will focus in the OPD or IPD, we need to keep the patient and then assess. But here the skill can be assessed in the multiple settings. So every time you can able to improvise our trainee in the different settings. That is the first thing. And second important thing is, here we will give a feedback immediately. It is a real-time workplace-based assessment, where immediately after the assessment, you are giving a feedback so that the trainee can improve himself. Even in short case also, we will say the corrections, but it will not be continuous. So this is a basic difference which we will observe between the Mini-CEX and short case discussions. So this is all about theoretical part of Mini-CEX. Now we will have a role play or a demonstration. So now I will call upon our postgraduate, Dr. Jansi final year, and our house surgeons, Dr. Deepak and Dr. Praveen. So the setting I will explain. So this is an emergency setting. So the interview will be going to happen in an emergency setting, where the patient, he is a standardized patient, is brought, I am specifying, he himself didn't come, he was brought by his father and he was made to come to an emergency. So here we are going to focus on what are all the skills. We mainly focus on the history taking brief and examination. So unlike in the other specialties, like we will do systemic examination, we will mainly focus on mental status examination, which is very important for us, like attitude, behavior, psychomotor activities, speech sample, thought content, and higher mental functions is the main thing which we are going to focus here. So this is the basic setting. So now I call upon our postgraduate and house surgeons to start the demonstration.
Hello, Sallu bhai. How are you? Okay, I will talk to you later.
Hello, myself Dr. Jansi, and I'm a resident here in the Department of Psychiatry. I got a call from emergency department regarding your case, and I'm here to help you. Please introduce yourself.
Myself Deepak.
Okay.
This is my father Praveen.
Okay. What's the reason for your presenting here?
There is no reason of presenting here. It's just that he brought me here. You can ask him.
Okay. You please tell me what's the reason for your attendance here?
Ma'am, from last 3 weeks, he's having irritability, restlessness, and excessive talking, ma'am. Deepak.
Do you need to tell her these things?
Okay, Deepak, please.
Ma'am, today morning I shouted at him, ma'am. He got angry and broke our TV, ma'am. So we got scared and we brought him to GH, ma'am.
Deepak, what your father is telling, is that true?
Yeah, it's true.
Okay. Based on the complaints as said by your father, probably you are suffering from a mental illness.
Mental illness, huh?
Yeah.
Do I look like mental?
Deepak, calm down, please sit. Will you please elaborate how it has developed, all these symptoms?
Ma'am, before 3 weeks back, he was normal, ma'am. He used to go to college every day by morning and he come back at evening, ma'am. But from last 3 weeks, he's going to college but coming back too early, ma'am. And he's not even attending any classes. If I ask him something, he gets irritated and he gets angry. And even at night times, if I ask him to sleep, he says, I don't need sleep. I'm not like you. I'm not like everyone. Little amount of sleep is enough for me, he says, ma'am. And even recently from last like 3 weeks, excessive talking has increased, ma'am. He talks with unfamiliar persons.
Deepak, come. Please calm down and please be seated. Deepak, what your father is telling, is that all true? He's telling that you are not sleeping at night.
Yeah, I don't need sleep like you.
Why?
I'm good. I am too busy to sleep.
Okay. Is there any other complaints apart from this?
Sometimes he talks himself, ma'am.
Okay. Deepak, are you talking to yourself?
Yeah, I am just responding to whosoever is talking to me. That's it.
Okay. Whom are they talking to you?
Actually, God is talking to me.
Okay.
He's telling me that I am his special child.
Mm.
He has given me all the superpowers that anyone can have here.
Mm.
I can even make a dead person alive. So all the superpowers is all with me only.
Mm.
That's all. I'm his special child.
Okay. Apart from God, is there any other voices coming to you?
I actually talked to Chandrababu Naidu as well.
Okay. Regarding what?
He asked me about what policies he has to implement.
Mm.
I tell him.
Mm.
Then we discuss a
Mm.
lot of things actually that are all confidential. I should not tell you first. Okay. Then yesterday I talked to Narendra Modi as well.
Mm.
Actually, he's planning for an attack on Pakistan.
Okay.
So I am telling where and how to do.
Is there any other voices apart from Chandrababu Naidu, Narendra Modi and God?
Yeah, Salman Khan is there.
Okay.
He is actually asking me about acting tips
Mm.
and his upcoming projects as well.
Mm.
He invited me to his Bollywood party as well.
Okay. Have you went there?
No, not yet. I have to go.
Okay.
See, already Naidu Babu is calling.
Okay.
I have to take this call.
Wait. Is that necessary to make that call now?
Yeah. From last 5 days, I am giving him time. So postponing every time. So today is the day. I have to go.
How much time it will
2 minutes.
Okay.
I'll just go.
Is this the first time or he had presented these symptoms earlier also?
Ma'am, this is the first time, ma'am. And I forgot to say something, ma'am.
Mm.
From last 3 weeks, he spent more than 1 lakh, ma'am. I asked his friends. They told that he took 60,000 from them.
Mm.
And last night, 40,000 was missing from my cupboard. Today morning, I asked him, have you saw that money? He told, I took that money, I spent it. I shouted at him. He got angry and he broke the TV. So I came to GH.
Deepak? Your father is telling that you had spent more than 1 lakh in 3 weeks. Is that true?
Yeah, it is actually true.
Okay.
I did.
For what purpose you had spent that much of amount?
See, I have standards. I am overpowered person.
Mm.
I have to take care of everyone. So I donated those to poor people. I want them to be happy. That's my duty as well.
Means you donated the entire 1 lakh to poor people?
No, only 60,000 I donated.
Mm.
Rest 40,000 I donated to myself.
Okay. Regarding what?
Regarding, I bought a new phone.
Mm.
I bought one new watch as well. And put some money on my clothes as well. I should look rich, right?
Mm. Okay. All those are necessary right now?
Yeah, very necessary.
Why?
You see, I told you I have standards. So I should look handsome. So that's why I groom myself well. The old phone I had had only 1 camera. This one has 3 cameras. So for better pictures, I took this one. You know what? See this. I can see timings in every country being here also. So that I know what is happening where.
Okay. Okay, will you cooperate with me for a few more minutes?
No, I am actually getting another call.
Deepak, it's just few minutes.
Okay.
Okay. I'll ask few questions to know you better. Okay. Could you please explain me how was your mood most of the time in a day?
I am very happy. Always very happy.
Okay. Is there any particular reason for your happiness?
No particular reason. It's just that I am happy. You should be happy as well.
Okay. Can you please tell me what was your favorite festival?
My favorite festival would definitely be Diwali.
Okay. Will you please elaborate in detail why it is celebrated and how it is celebrated?
See, Diwali is a festival in which we celebrate the success of good over the evil.
Mm.
You know Kalima, She had so much powers. Like me. Like I have so much powers. I can do anything I want. Wherever, whenever I want. I can make a dead person alive as well. So that is why that's my favorite festival. That day, actually I'm very busy now, so I'll complete all my works in the morning itself. At night, I will go in rounds. Like with my friends, I will go, we'll roam. Actually, I came in my Mercedes-Benz car, you know.
No.
I have a red Mercedes-Benz car. In that, we will go Hyderabad for biryani. Very good biryani there. One more Nilofer cafe is there. We'll get good tea there. You should try once.
Okay. You are telling that you are having some superpowers that was given by God, right?
Yeah.
Is that possible for a human to have such powers?
Yeah, definitely I have. You can't even imagine how much powers I have.
Okay. Are there any circumstances that it has been proved that you have such powers?
Yeah, definitely. There have been multiple circumstances.
Like? Give me some examples.
Like, you know COVID, huh?
Yeah.
You know how it was stopped?
No.
I only stopped that.
Any other?
You know Japan?
Yeah.
Japan is so much prone for earthquakes. Yesterday itself I stopped an earthquake.
Okay. I'll give you some scenarios. Please tell me how will you respond in that scenarios, okay?
Okay.
If you are in a building and you are the only person in that entire building and suddenly a fire accident happened in that building, what was your immediate next step?
I will go stop that fire.
Okay, how will you stop that fire?
I have superpowers.
Okay.
I'll do this. It will be stopped.
Okay. I'll give you another scenario. You are going by walk on a road and you suddenly come across a letter which was enveloped and it has been missed by some other person. What will you do?
I will just send that letter. It will go to its designated place.
Okay. We'll conclude this discussion. Wait. Few minutes. I'll ask one more last question. Please tell me whether you are having any illness or not.
Me?
Yeah.
I don't have any illness. Do I look like ill?
Okay. Deepak, let me explain you that based on my observation, you are having mental illness that is called as mania and it has to be treated. But you are not in a condition to understand your illness, okay? Don't be panic, okay? Just wait for a few minutes outside. I'll talk to your father, okay?
From that time only I wanted
Thank
to go.
you. As I said, your son is having maniac illness, and for this condition, it has to be treated acutely.
Okay.
If not, he'll be landed up in worst situations, and this condition will aggravate. Okay, my advice is to be on regular treatment as we prescribed,
Okay,
and be compliant with that medication and come for regular follow-ups.
Okay.
If you do what like what we say, he'll be okay and he'll be manageable. If not, it's not manageable and it will be poorer outcome. It will have poorer outcome. Okay?
Okay, ma'am. Okay. Thank you, ma'am.
Thank you.
I really thank our postgraduate, Dr. Jansi and Dr. Praveen and Dr. Deepak for helping me to carry out this demonstration. So now the next session is I am going to give a feedback. So this I will give it for 1 to 2 minutes. So we have mainly focused on interviewing skills. So initially she has done the interviewing skills well, and examination, as I told, mental status examination, she has concentrated well on the examination part, and judgmental capacity also is very good, and she has counseled well. But however, there are certain areas which a trainee needs to be improved. So the first thing is, we cannot confront with the patient by saying mentally ill. So we should more empathize the patient by putting ourselves in the shoe and think about the patient's condition. That we need to improve. And second thing is, focusing on the specific skills which you need in an emergency setting. So since it's an emergency setting, we can focus on a particular key aspects for our diagnosis, and once we can make out the diagnosis, since he is very restless, we can talk to the patient's attender and we can give a sedative injectables, preferably intramuscularly, so that it takes time to act. Meanwhile, we can complete our interview, and the counseling can be given still more better way, so that they can have a more judgmental capacity and they can believe our treatment and they can continue with us. So these are the things which you can need to improvise. So this will be the feedback part which you can give at the end of Mini-CEX. So every skill you can assess and you can give the feedback in such a way so that high quality care will be delivered to the patients. So last two slides. So what are the strengths of this Mini-CEX? So it is a real-time workplace based assessment where and all you are assessing you can give, which I already told, immediate feedback which fetches the trainee to improve themselves, and focus on the specific skills. We are specifically focusing on a particular skill which you are going to do. So the square mark you can tick it, and which you are not going to perform, you can put an into mark on the square of the 7 parameters which you are going to address. And flexibility you can do at any place where and all you can want, and it is a structured, and giving feedback will improve the trainee as well as you can give a utmost care to the patient, but still it has some limitations. So we can assess only a limited skills, and the time taken is very small. So if the case is complexity and if the case is more complex, we cannot able to assess the particular case, and the trainee will be under the stress if you keep on assessing in the multiple levels. So these are the some of the disadvantages this Mini-CEX. So with this I will conclude. Next ask a session will be taken after the lunch. Thank you.
Thank you, sir. Now we will break for lunch and will assemble at 2:15 sharp for the post-lunch sessions.
So good afternoon. Welcome back to the post-lunch session. So now we'll have the OSCE and OSPE stations. So I request Ramya Madam to just elaborate of what next is going to happen.
Slide number.
Good afternoon, everyone. So we are talking about assessment of skills. So one such assessment already Mini-CEX has been demonstrated. So this is a very commonly used practice. It is called objectively structured clinical examination. Then it is called OSCE. Practical examination, we call it as OSPE. So all of you, most of you must be knowing how to do this and what is the use. So let us not go into the details of all that. So these are the steps in conducting the OSCE stations. First we should set up the stations. For that we should know what skill we have to test. We have to list down the skills which we have to test and then set up the OSCE stations. We need a blueprint, a checklist, very important, a checklist for observation in the procedure stations. The examiner will only use the checklist to say what has been done and what has not been done and gives the marking accordingly. So it is extremely objective. There is no subjective opinion in this type of skill assessment. So this is how an OSPE stations will be designed. If the OSPE stations are 5 or more in number, we should have a rest station in between. Usually in competitive exams, they have more than 10 or 20 OSCE stations. So this is how it will be set up. Supposing there is a rest station. So here you see station 1, station 2, station 3 and the station 4 is missing. So station 4 will be the rest station. So it's not shown here. So we'll have a small demo. So we have set up OSCE stations. We have set up 4 OSCE stations. Now among the participants, you are the ones who will be conducting the exam. So there are questions, there are checklists. So very quickly, as it is we are running a little late, so I quickly want 4 participants. 4 participants quickly from each group. 4 participants as students. You will be rotating to all the stations. So who want to be the students? Very quickly. Yes. Dr. Ashish. Then? Very good. Geeta. 2 more? Yes, sir. 4th participant. Who wants to be a student? Very quickly. Anyone from these 2 groups? Okay. So all the students, please go to Dr. Siddharth. He will explain. Now, I need 8 observers. 2 from each group. Again, very quickly. Observers, you don't have to do anything. You very quick. So all the 8 of you, please go to Dr. Lokesh. Sir will give you instructions. Now, we want examiners. 4 examiners. Please come to me. 2. 2 more. Okay. So Kavya, Mauna, examiners, you can come here. Examiners. Oh, they are all observers. Okay, Sai Tejas, sir. 1 more examiner we want. Okay. You come here. Okay. We need 2 people to maintain time. Okay. Yeah, they both. Yeah. You both stand there. You just be there. I will tell you. So. So the examiners have been given instructions. So the others who are here, other than the people who keep the time, the others will overall observe how the procedure is going. At the end of this session, we will ask you your inputs. No, అన్ని చోట్ల రాసేది ఉండదు, ఒకటే రాసేది, ఇంకంతా చెప్పాలి. Excuse me, we need 4 more volunteers. We need 4 more volunteers as simulated patients. Vijeta ma'am has come. 3 more, yeah. Priyanka, Sairam sir, and one more person. We want them to act as simulated patients. Shalini, come. Okay, come. So Geeta and Joshna and Hemant. So timer set cheskoవాలి. 5 minutes. Bellu much. Where are the students? You can stay here. You stay away from the general discussion. 1, 2, 3. Sir, Anil, sir. Okay, 4 students. Okay. Now I'll give an overall instruction. In each OSCE station, the student will stay there for 5 minutes. Just 5 minutes. At the end of 5 minutes, a bell will be given, and the student has to move clockwise. So at the end of 20 minutes, all the 4 OSCE stations will be covered. The examiner has to do the marking in the checklist. As simple as that. So shall we start?
There are instructions given for each OSCE station. You should not ask anything to anyone first. You have to follow the instructions and do that. And observers will be there. Overall 5 minutes for each patient. And every 5 minutes you ring the bell. They will be doing their duty.
And yeah. And please remember, this is not I'm telling for the students, this is not going to assess your performance. She is from ophthalmology, she might not know what is there in that. So we are not assessing your personal performance here. It's definitely not like that. Just a demo of the OSCE stations. You have to see how the procedure goes on. So are we good to go? Okay, so you can go to no problem. Nowhere your names, only the scores will come, scores for each station, but nowhere your names will be there. So please don't take tension. Let's all be very sportive and let us start. Yeah. Okay. Are we good to go? Yeah. You go to station number 1. So Ashish, you go to station number 2, 3 and 4. 4 stations. When the time starts, I will tell you. So 5 minutes from then. Others can observe. Now 2 observers have to be in each station. Observers, please. Who are the observers? 2 observers should be present in each station. Not overall. 2 observers have to be in each station and you be there only. Yeah. 1 second. Yes. The time will start. Start. Please move to the right hand side. Yeah. Start. Yes, time up. All of you can come back to their seats. Big round of applause to all the participants for being so sportive. Examiners, please give the total of your scores. So who were the observers in station number 1? Let us have a quick feedback. So please sit down. Please sit. So please give your feedback, sir. What did you think of that station? In general, comment on the type of question kept. How were the participants? How was the examiner? What went well?
In station 1, it is about how to, a 25-year-old came with hearing loss in the right ear. It is about how to perform a Rinne's test. All 4 people students have performed the test well. And the examiner has given relevant marks based on their examination.
Any input, sir? Same? Anything which you thought could have been done better? They didn't do that. So the participant, the student did not greet the patient and did not say thank you. Yes. Anything else? What could have been done better? No? Okay. Thank you. Group 2, who were the observers in group 2? And? Your findings, sir?
It was about counseling a patient with a terminal cancer, lung cancer. It all went smoothly. All the students were good. Assessor was good. I think the introduction to the patient, some students they didn't do, and some they need to be more compassionate while counseling.
So what kind of skill is that? Communication skill. It's a very, very important skill in which we have to train our students. So most of the participants find it difficult in these kind of situations, even for us. So when we started the practice, it is a very difficult thing to break bad news to a patient. Who was the other observer, sir? Same thing, anything you want? They missed introducing themselves. Okay. Okay, good. Group 3, who were the observers in group 3?
So it was about taking informed consent for the procedure tubectomy. So all the 4 participants did very nicely. And the thing is time constraint, ma'am. So they didn't take in consent completely. So they explained till the procedure and its complications, that's it. But final acceptance of the patient, it didn't come to one conclusion. But it was nice by everyone, ma'am. Very good.
Okay, so most of them did not conclude. They did not cover up they did not say yes or no, or they did not properly convince the patient. That's what you mean.
They didn't convince the patient till the end.
Okay. So it was time constraint. Okay. So we could have given more time. Okay. Thank you. Group 4. Observers in group 4.
Good afternoon, ma'am. It's about ECG interpretation, what was in group 4. So actually our examiner was good. Actually he was saying how to do, he explained what to do, and then the students, No, ma'am, he didn't. He just said what is the thing to do, and then the students they are very disciplined actually. And one thing I observed here, the students cannot cheat or anything. Like it will be very correct and smooth going, and we can assess properly in this.
Fourth OSCE station. Fourth OSCE station was testing the knowledge domain of the aspect. So all the 4 participants did well. Examiner was also observing student without any interference.
Thank you, sir. So thank you for your inputs. Group 2 and Group 3, nobody told how the simulated patients were. They were too good. So big round of applause for the simulated patients. Thank you. Now let us just compare the scores of each station, not each candidate. Okay. Station 1, that is performance of Rene's test, overall score is 17 out of 20. So that means they have done a good job. Station 2 is 15 out of 20. Breaking bad news. That's excellent for the kind of station which we have allotted. Station 3 is 13. Taking consent for tubectomy. The score is 13 and station 4 is also 13. So we have assessed, we know the scores of each station. So what do we understand by this? Station 1 has got 15 means what? All have performed well, that is one aspect. The station might be very easy. That is also another aspect. No examiner bias in OSCE because it is all objective. It is objective, there is a fixed amount of time for each station. Station 2 and Station 3, why do you think, where do you think the scores were comparatively less? It was 15 out of 20. So where do you think we can improve? Time constraint, yes, that is one. Any other thing? Yeah, that we specifically asked them to ask a lot of questions. Simulated patients. I think they have done a very good job. Okay, so that can be done. See, these 2 stations were involving communication. So we will have to train the student in this aspect. Psychomotor skills, because it was easy also, they did a very good job. But Station 4 got less marks because it was a cognitive aspect and we are all not students. We are all in different specialization. But taking into consideration an MBBS graduate, a cognitive aspect station, usually they get the maximum marks there. Because that does not involve any talking, any skill, there is nothing. They just have to see the question, write the answers and go. So based on this, once we conduct an OSCE or OSPE exam in our respective departments, we have to assess the output and see how we can modify it or how we can improvise on that. Overall, any inputs, any observations anybody wants to tell? I'll wind up my session.
I think it was a very well done session, ma'am, but only thing was what I observed is the observers were prompting the students, like you read the question properly, what are you supposed to do, read the question twice, what is that you're holding, like that. There were a bit of promption by the examiner. Okay,
examiner or observer?
I mean observer. See which, listen to, like which ear is he complaining, now okay. Which ear are you examining? So
giving some clues.
He said left ear you are examining, right ear, read the question properly, do the procedure properly. This was something the observers were doing to the students.
Okay. So that was just a demo. Actually, when you conduct an OSPE and OSCE, there are no observers. The whole point was to make everybody involved. That is why we said 2 observers per station. Nobody should feel like left out. So, and also it's an experience for you to see each student come in and do Actually, when we are doing an OSPE and OSCE, there are no observers. There is only an examiner and a student who does moves to the next stations. If the stations are more than 5 in number, we have a rest station. That's all. So this, it's a relatively easy way to assess skills. Only thing is we need meticulous planning. There is manpower required. So imagine there are 20 OSCE stations. We need 20 examiners. So that itself is a task. Designing, logistics, planning, all these, a lot of things go into this. But then once you do it, it's a very nice way to assess the skills of a student. Thank you.
So, good afternoon everyone. So, I'm back with another topic of drafting of a schedule and assessment plan for the subject. So, 2 days we have been hearing about how to plan skills, how to plan assessment, how to plan Atcom module, what are the things present in the CBME curriculum, the competencies. So, everything heard. Now we are trying to put everything in a single schedule. So I'll be talking about that in my next few minutes. So before going, so the session's objectives, to understand the steps in drafting the schedule, competency-wise, for lectures, SGDs, that is small group discussions and clinical postings, and to understand the steps in drafting assessment schedule. So now we'll be doing, at the end of the session, every one of you will be doing a hands-on activity of doing a schedule for classes and the assessment. So before that, how many of you have the experience of drafting schedules for your department? Yes. Great. So you're all the registrars or HODs of your respective departments. So what are the difficulties you face while drafting, sir?
Proper teaching learning methods to selection of this method.
Selection of
proper TL method.
Teaching learning method.
Mostly nothing difficult.
Thank you. Thank you, sir. What are the challenges you faced while drafting?
Like sir told, selection of a proper teaching method was one, and what I noticed was when I was registrar, a few important topics were left out from the CBME curriculum. For example, so we were not able to find few important topics in the, we were not able to find the competencies. Yeah, yes. So that was a challenge for us. So I asked our HOD, he said, you just write the topic and leave the competency blank. So that's what we did.
Thank you so much. What challenges you faced while preparing?
Sometimes there's cancellation of the classes. Again, to squeeze them into the schedule which is already made is the...
I do agree. So suppose for any reason the class have been cancelled and we don't know again where to go and fit that class. Yes, thank you. Someone raised your hand in this group. No, nobody raised. Yeah, please.
So, sir said no ma'am, some topics, some competencies were not there in the curriculum. So those are very important topics like complications of CSOM, which is very important for everyone to know, but it's not there in that competency. So we don't know where to include it. And even SDLs also ma'am, like self-directed learning, teaching method is also not there in our thing. So where to fit in those schedule, we don't know.
Thank you.
Difficult to cover all the competencies
in the schedule in a given year. Last year also we missed some topics in pediatrics. And one more thing is for small group discussions also, we don't have sufficient faculty. Only 4 to 5 faculty in our department, so it's difficult to engage faculty for the group discussions and also for lecturers.
So for small group discussions, there is a deficiency of faculty in some departments to plan. Pediatrics department.
Alignment and integration process, ma'am, which competency to be taught to the student. One was what were the competencies that were covered in the previous years was not known clearly, and which topic to align was going on in surgery or OBG and gynec was not known to me. So I had to choose a topic randomly like competency. That was one challenge that I had. Next, the thing is there are certain competences which are bedside clinic, but afternoon 2 to 4, since they do a morning bedside clinics, so it is hard to cover all the competences bedside clinics even in the afternoon classes and the skill lab those session, because we generally assign one faculty for the 2 to 4 session. So the faculty assignment, 3-4 faculties are required, and dividing the students is required for the 2 to 4. But in the morning, those competencies, the clinical settings can be covered. But if we take like that, the clinical posting students will be like 40. Rest of the 40, when will they cover is not known. So this bedside clinic competencies, how to cover is one more question that I got. And the third question was this interpretation of chest x-rays and all, blood investigation interpretations. There are also complex, complex competencies. How to cover this complex competency, interpretation, SGDs, which is a tedious process and challenge of this interpretation. These were the problems.
So for the uniformity of competencies for the bedside clinics, you can have a structured schedule, which the same schedule you can follow for the subsequent batches, so that the same competencies you are teaching for the other batches coming. They can have a structured schedule for bedside clinics also, mentioning the competencies and the topic going to be covered. And the same structure should be followed for all the batches coming for the clinical postings. That makes the things easy for making uniformity for all the batches. And the competencies that has been covered in the bedside need not be repeated again in the theory classes, depending on what you decide, your priorities.
Madam, I have something to say.
Yeah,
so, Srikanth sir said some of the topics which are important, they have not been given in CBME curriculum. And when we look at the competencies, it is difficult for all the competencies in medicine to also to cover. So we cannot be sure which competencies to leave sometimes. So we'll cover which of them are important. Those are the 2 points. And third one is, very often we'll not be able to integrate the classes with the other branches. So I feel there are 2 different kinds of learning, block learning and interleaved learning. Block learning means we are going to learn, like whatever we are doing, integration is block learning. If we, let's suppose if I do thyroid now, and in surgery, if the thyroid is done after a month, it comes under interleaved learning. There is overlap of the topics, but with a definite gap. The student will have the opportunity to recollect. That is also good in some way. And one question specifically that I have is that previously, last time, when what we did was, I took the entire cardiology or whatever the branch, but it takes a lot of time. It takes a period of 2 months for me, even if I take once weekly class. Now, what our faculty, what our HOD is suggesting is that an entire subject. Each one faculty will cover one topic from each subspecialty. I'm not sure which should be preferred.
So previously they were doing, one faculty was covering one chapter, and now the HOD suggested like one faculty should take one topic.
Madam, let's suppose
not the whole chapter.
There is cardiology. There are 10 chapters in cardiology. What I used to do, last time what we did was, I used to take once weekly class, and in the eventual 10 weeks, I used to cover entire cardiology. So cardiology will be on my head. That is what I used to do. Last time it was done like that. Now what is being suggested is that if we have 3 classes every week for general medicine, within the next 3 weeks we'll have 9 classes, right? So each class will be taken by a different faculty. So that by the end of 3 weeks, the entire cardiology will be covered. Yeah. By different faculty, not by me.
Yeah, that's fair enough. Because see, the problem is, if you're going to give one faculty the onus of taking the next 20 competencies, that faculty also should, with among all other duties, your all other clinical commitments, your PG classes, he can only do once a week, like he very practically put it. So because of that, this cardiology will get stretched for the next 2.5 months, and it will be in bits and pieces, right? Instead, what we are trying to say, we are aligning. Suppose we are doing cardiovascular system, then in medicine they are doing cardiovascular system. You assign as many faculty as possible, but it is basic. Any general medicine teacher should be able to teach cardiovascular system. And if you have any extra expertise, of course you can be asked to take a small group session, give a case-based problem so that the nuances of cardiology can be highlighted. But I think this is one good way of finishing it in the next 2 weeks, 3 weeks, is what is better in the long run, in the sense that you move, one system is finished and you go on to the next system. So both ways it can be done, but I would prefer the second way for the sake of the students, and also it is not putting so much pressure on one faculty, I have to finish this so many competencies. Suppose he falls ill, or he has to take 1 week leave in between, or he is being sent for some other program. And then it is not as though anybody else can't teach cardiology, right? So it is better this way, Dharani, that it gets distributed among all your faculty.
Thank you, madam.
Thank you.
Thank you, ma'am. So the next few minutes I'll be going through the steps of drafting. So I request you all to please kindly look into the slides carefully, because this is where we usually face challenges in preparing the timetables, especially aligning with the other departments, calculating the hours, calculating the topics, how to fit the topics in your schedule. So is all. Okay. So we all had this habit of looking into the schedule before going to class or college. So what topic I'm going to learn today. Hopefully everyone here, now this generation kids don't have, definitely. But at least we used to have that habit. So teaching schedule, it is a list of times when particular activities or events that will happen. So it contains all the list of events that organizes the teaching activities throughout the day, a week, a term, or a year. So it shows exactly what is to be done at a particular time. And a teaching schedule consists of a list of complete set of offered courses as well as the place and time. So most of the clinical departments will be agreeing with me. So medicine, surgery especially, will be having classes from second year onwards. So you have classes for phase 2, phase 3, part 1 and part 2, and sometimes they may overlap and you get confused. Instead of going to lecture hall 3, you go to lecture hall 2 and lecture hall 1. So it happened to us. So the schedule, we have to specify the venue, the timings, and the topic and the faculty. So why is it important? It directs the attention of the learner to one thing at a time, and the learner's energy is automatically directed in a particular direction. So the first step in drafting a timetable. So we have to see in each phase what are the subjects present according to the GMER. So we have these graduate medical education regulations. So they have been first released in 2019 and later they have been modified for 2022, 2023 and 2024. Latest we have GMER 2024 for 2024 batch, and GMER 2023 we are following it for 22 and 23 batches. So the current phase 3 part 1 and part 2, part 1 students, we should follow GMER 2023, and part 2 students 2021. So 2021 who are in final year, they will be having only a 12 month of final year, but then 22 and 23 batches will have 18 months of final year, 17 and a half, 18 months. So we have to draft in each professional year. First year there is no confusion because they will be having only anatomy, physiology and biochemistry. Confusion starts from second year. So they will be having path micropharma, forensic, and they will also have the introduction to clinical subjects. Your medicine, surgery, OB-GYN will be there. And again, third professional, what are all the subjects present? And between part 1 and part 2, they will be having 1 month of electives. And then third professional, part 2. So once you document all the subjects present, so here, in this next presentation, they are taking an example of OBG department. So OB-GYN classes will be there in second year, final year part 1 and final year part 2. Then this is the academic calendar given by the NMC. So they will be having approximately 42 weeks of time. So they will exclude the 10 weeks for university exams, internal exams, and 3 weeks of vacation and 2 weeks of public holidays. So the working weeks will be mentioned here. Similarly, for phase 3 and phase 4, they will be giving the total available weeks of time. And then we will see the number of teaching hours allotted to each subject in phase wise. So again in the GMER, they will be giving for each phase, for each subject, how many hours of lectures, how many hours of small group learning, how many hours of clinical postings, how many hours of SDL, and the total number of hours. So someone was telling we don't know how to divide between lectures, small group. So they have already given the number of hours of minimum number of SDLs to be covered, small groups to be covered, and lectures to be covered. Okay. So in this example, OBG department, they need to take some 75 lectures in second professional year and clinical postings of 540 hours. It's inclusive of medicine and surgery. Then distribution of teaching hours again in final MBBS part 1 also. So how many lectures, how many small groups, how many SDLs, total hours. I'll share you the GMER documents of all the 3 years with you. And distribution of teaching hours in final MBBS part 2. So how many teaching hours, how many SDLs, how many small groups, and total hours. So by this time, we know how many hours of OBG in second year, how many hours in final year part 1, and how many OBG hours in final year part 2. So we will get the total number of lecture hours. So once we get the total number of lecture hours, total number of small group hours, total number of SDLs, and you know the syllabus. So you all have done the exercise of writing competencies, breaking into SLOs, and deciding whether this can be taken as a lecture. You assign the TLMs. So whether it can be taken as a lecture or a small group or a SDL. So you all have that data already. So only thing is you have to add it into your schedule. So second year, these are the chapters I am going to cover. So in these chapters, these are the topics that can be gone for lecture. These are the topics that can be given to SDLs. These are the topics that can be given as small group lectures. So you divide and put them in your schedules. So by seeing the competencies, you prepare the subject lecture list as per the competencies. So you describe the theory and practical teaching modalities as per the CBME inclusion. So based on your subject curriculum, you can place your competencies, whether it belongs to didactic lecture, practical, whether this topic goes for integration. You divide your topics into these things. So what topics can be given as SDLs? What topic can be going for Atcom sessions? What topic you want to teach them in simulation labs or skills lab? What topics you want to teach bedsides? So there may be a few topics which you can teach bedside and may not be repeated in your theory classes. So trust me, once you do this exercise, sitting with all the departments and sorting for a whole batch from second year to final year, it makes things easy for next academic years. So 1 year if you put your hard work in, every year, subsequent years, you need not do the same exercise again and again. You only need to change the dates. That's the max. And the name of faculty you may change. But this skeleton and all, please, you can prepare it beforehand. Then, once you have the topics, what is lecture, what is SDL, this thing, and you will be given the master timetable by the institute for each phase. So, the phase coordinators will be giving the timetable. So, Monday morning, whose class, 8 to 9 class, 9 to 10, whose class, 10 to 1, they will be going for clinical posting. This is for the phase 2. Example, and 2 to 3, 3 to 4. So, we are not having this 4 to 5 in our institute. So, based on the schedule given to us, based from the competencies, you pick your topic and put in the schedule. And we already have the number of weeks. So, this timetable will be repeated for like maybe 35 weeks or 36 weeks as given in the teaching schedule. And preparation of subject teaching schedules as per allotted hours in the master timetable. So, you prepare for your department, you insert your competency, the topic SLOs, and the faculty name who will be taking, and whether it is you can color code, like whether it is a theory class or a SDG or a Atcom session or a integration session, or it is a nesting or correlation, whatever you can color code. So if you observe, there is a color coding for medicine department in pink, surgery they have a different color code, and you can insert your topics in this master timetable. And how to prepare a clinical posting schedule. So again, how many weeks of course they have, we will see each phase. So this clinical posting schedule is already there in the GMER. For example, a phase 2 MBBS students should undergo medicine, surgery, OBG for 4 weeks, pediatrics 2 weeks, ENT, ortho, total of 36 weeks of postings they will undergo. Similarly, in phase 3 part 1, 42 weeks of postings. And phase 3 part 2, it's 40 weeks of clinical postings. So based on this, you prepare the clinical posting schedule for a whole year. And each department will be preparing their clinical posting roster. For example, OBG, they will be coming for 4 weeks. So in that 4 weeks, Saturday is a holiday. So 6 days in a week, 3 hours per day. So you will be drafting your schedule like day 1, day 2, day 3, what topics you want to cover, and the competencies, what is the domain and suggested learning method, and who is the faculty, you can write it later. So even for the clinical postings, you have to follow from the curriculum, see the competencies of what you are supposed to teach, and prepare a schedule for the 4 weeks of your posting. And how to prepare a master timetable schedule. So there are allotted hours for each subject in the clinical posting slots and time schedule. So clinical postings, not all the students will be coming to the same department at a time, right? So they will be divided into batches. So most of you must have seen the clinical posting schedule which you receive. So batch A, batch B, batch C, batch E, D, F, and they will be rotated to other departments. So depending on the number of faculty and number of weeks, we will divide them, and then you rotate the students. So batch A will go to medicine, batch B will go to surgery, batch C will go to OBG, batch D will go to 2 weeks of pediatrics and 2 weeks of ortho. And then after 1 month, they shift to the other slot and they will rotate. I'll just show you the template. So this is the template of clinical posting schedule. So either you can have the subjects row-wise or column-wise, your feasibility, and then you divide the students based on number of the strength. Suppose there is a total of 150 strength, and you want a group of 30 each in a batch. So you can divide into 5 groups. Or if you want 25 each, 6 batches of 25 each, batch A to batch F. So you can have batch A, B, C, D, E and F. So depending on total number of weeks. So this is an example taken for second MBBS format. So 4 weeks of medicine, 4 weeks of surgery, 4 weeks of ophtha, 4 weeks of OB-GYN. In this example, they have divided into 4 batches only, so it is only A, B, C, D. Okay? So February to March, they will first go to A, B, C and D. And the next month, this D will come to medicine and ABC will go to surgery, OB-GYN and ophtha. Okay? So after this set of postings are completed, they can again shift to the other set of postings. Here it is mentioned C1, C2 because this is only for 2 weeks. So the first 2 weeks they will go to pediatrics, the other 2 weeks they will go to orthopedics, the same set of students. Are you observing this table? Please try to observe. I will give you a hands-on. So when you start writing, then you will have a clarity. So, yes. The first phase, they will be having only the classes in the college. And the last thing is how to consider exam schedule for formative and summative assessments considering allotted hours for phase prepared by the university or institute. So as you all know, we are supposed to conduct, so PCT here stands for part completion test, what we call as internals. So we have to conduct 3 internal exams. The third one should be the model of university exam. And we also have to, at the beginning of the academic year only, we have to plan the dates for the internal exams which will happen throughout the year. The first internal date, second internal dates, third internal dates. So university exam dates are not in our hands. It may vary before or after depending on the YSR declared dates, but university will be giving an academic calendar tentatively when the exams may be there. So based on that, we have to plan our academic year. So when we are supposed to plan our part completion test, 1, 2, the prelims and the university exams tentative dates. Okay, this is how you plan. So for the UGs, phase 1 when they will have their exams. Phase 2 when they will have their exams, phase 3 when they will have their exams, phase 4 when they will have their exams. This total template we will prepare for the whole year. So each respective phase coordinators will prepare for each phase. And to prepare the time schedule for theory and practical exams at the time of each exam. So theory, all of them together will write on the same day, then that's not a problem. But practical schedule again, I think you are all aware of that. Batch wise they will come on rotation for all the 6 days. And we also have for 21 and 22 batches, this is the template of internal exams marks. How many of you are aware of this marks distribution? For 21 batch and 22 batches, we are supposed to submit the marks in this format. So you have the part completion marks, the internal marks and some home assignments. We are supposed to give some seminars, continuous class test, museum study, library assignment, attendance. So all these carry marks in the internal exam marks. So this is for theory and this is for practicals. So benchmarks are targets that have to be fulfilled. They cannot be fulfilled in an indefinite period of time. So there are timetables in benchmarks. So we should have a definite time period, and having a definite set of timetable is very important for us to fit in our curriculum. So with this, we have a group activity. So as and when you get doubts, I'll be clearing you. So group A will be preparing a clinical posting schedule for phase 2 MBBS. Group Blue will be preparing a clinical posting schedule for Phase 3 Part 1 MBBS. So Group Green will be preparing a clinical posting schedule for Phase 3 Part 2 MBBS. Fifteen minutes time. Group 4 will be doing a theory timetable for Phase 3 Part 1. Group 5 will be doing a schedule for part completion test and prelims for Phase 3 Part 1. Three. పెడతా So assume to have 150 students and you can have a batch of 25 each. You can take March 1st as the commencement date. So assume March 1st as the date of commencement. Based on that, the number of hours.
Only forensic medicine and community medicine. Clinical postings.
No, I think you are given to do a theory type. So I'll project the template of the clinical posting example. Okay, before that, so the group 5, you can take a picture of this. This is the template. You have to prepare only for Phase 3 Part 1. Assuming that the classes have commenced from March 1st. Yeah. So you can take the help of your laptops or Excel sheet. key. థియరీ కదా థియరీ ఇలా రాదు మండే ట్యూస్డే వెన్స్డే వస్తుంది 8 AM to 9 AM అలా వస్తుంది అప్పుడు ఏ రోజు ఏ టాపిక్ మీకు ఎలక్టివ్స్ వదిలేసేయండి మిగతావన్నీ మీకు టోటల్ ఎన్ని వీక్స్ ఇక్కడ చూడండి 39 వీక్స్ 39 వీక్స్కి ఒక చెప్తాను You can have even the batches on the top and subjects here. It will be easy actually. I have a suggestion for you all. Clinical postings, you can have the batches on the top and the subjects in the rows. కాదు ఇక్కడ బ్యాచ్ ఏ బి సి డి వేసుకొని ఇక్కడ సబ్జెక్ట్స్ రాసుకుంటే మీకు ఈజీగా ఉంటుంది. 5 more minutes left. Some template at least you have got. Prasthanikana.
Good job, madam. సార్ పాపం ఎంతసేపు సార్ చేస్తాం.
So please email your documents to the displayed email ID. Whoever have finished preparing your schedules, please email to this email ID. We'll display them. Yes, attention everyone. So we'll stop at this moment. So please share your completed documents later in the WhatsApp group, CISP WhatsApp group. So we will discuss the one prepared by Group Blue. So they were given to prepare clinical posting schedule for Phase 3 Part 1. So how many of the total weeks is your posting? 32. So it was total 36 also, out of which 4 weeks are electives. So they have prepared it for 32 weeks. 4 plus 4 plus 4, 20 weeks. So the other, okay, so they have prepared for 20 weeks as of now. They're supposed to prepare for 32 weeks. They have prepared for 20 weeks. So 4 weeks each for medicine, surgery, OBG, peds, and community medicine. And then they have rotated. So the first 4 weeks, this is how they go. And the next 4 weeks they will rotate. So batch A, medicine, and they will go to surgery in the next 4 weeks. In the next 4 weeks, community medicine and then OBG, and then. So this is actually doable for if all the departments have the same weeks distribution. So it is easy. So the toughest part will be for the next 12 weeks. So which you skip doing, sir. Yeah, so they'll complete it and share it. So when you have uneven weeks of distribution, 2 weeks, 1 week, 3 weeks, 4 weeks, so that's the challenging part. So all of you please finish your assignment later and share it in the WhatsApp group. So I'll wind off this session for now and we'll continue with logbook by Dr. Dinesh. Thank you everyone. So I hope everyone will understand how challenging it is to prepare a schedule. And all of you please be proactive in preparing and helping your coordinators to prepare the schedules of your department. Thank you.
So good afternoon everyone. So now I will be talking on logbook and clinical case records. So that is record maintenance. So coming to the overview of the topic. So these are the headings which I am going to discuss. First, what are the objectives of this session? And the definition of the logbook and portfolio. So what do you exactly mean by portfolio? What are the advantages and disadvantages of logbook and portfolios, and what is the basic role of a logbook, and what is the structure of a logbook, how we are going to frame a logbook, and finally about clinical records and conclusion. Group activity I already shared in the group. So once the group activity I will show here, you can prepare and you can mail it to us because of the lack of time. So before going to topic proper, why you are so much worried about logbook or portfolio, and what is the main theme behind initiating the logbook or portfolio? Can anyone tell from this group?
So what all topics are assigned to them, like what is their performance, the feedback? So how much they are improving in next time when they come.
So all that we can note down. So like it will be a record for like how the student has performed and fared throughout his year.
Thank you, sir. Any other guess?
Record keeping of students' clinical postings.
For the students, okay, well taken. So previously the traditional curriculum, we are mainly focused on norm criteria. But here if you see in the CBME curriculum which was implemented in 2019, the progression of a career or a course of a student is mainly depending upon the acquisition of the competencies. So once the competencies has been achieved, then only the student can be able to promote to the next level. So that is a basic thing. So the competency which has been acquired can be documented in the logbook, and it is evidence, and also will give the feedback so that the improvement of the student can be noted. So these are all the basic things why they have implemented the logbook and clinical case records. So by the end of the session, we all should know what is the purpose of the logbook, and second thing is what are the steps which is used in determining the logbook. So these two will be the main objectives of this session. So I think this slide came accidentally, or is there any relationship between a ship and a logbook? Just out of interest only this slide, because we are having continuous sessions from the morning. Anyone can guess? Journey, yes sir. Yes sir. Yes sir.
They'll maintain the records like wind speed and directions, latitude, longitude, which is very, very important for its smooth sailing. So.
Yes sir. Very nice sir. So the concept of the logbook came from chip log. So that is nothing but a fragmented wood to which a rope will be tied, and the knots will be thrown in the water. So the speed will be determined based on the knots, how much they move into the water, and the speed and the direction of the wind, all these things they will record in a book. So which is commonly called as log book. So that's why it came into existence, and we are using it in a medical education. Similarly, portfolio. Portfolio came from portfolio, which is nothing but an artist and an architect can have their leaflets or charts in a briefcase. So it came into existence as portfolio. This is the basic history how the logbook and portfolio came into existence. Now we will go on to proper topic. So what is logbook and what is portfolio? Any one difference? So logbook already we are discussing. Can anyone tell me about portfolio? Yes sir.
All the activities which a student do, like what are all assigned to him, so all come under portfolio.
What about logbook?
Like only specified ones are recorded in logbooks.
We'll see the clear-cut differences sir. No. So in simple terms, portfolio is nothing but recording of all the tasks and events which the student has achieved, and it is nothing but a proof of documenting evidence which has been there in the logbook. So that is the basic difference between a logbook and portfolio. So what is a logbook? It is a verified record of progression of a learner. So what and all he has acquired knowledge, skill, attitude and competencies we will record in a logbook. Portfolio is nothing but collection of learners' progression in tasks and competencies. It is an evidence of events which are documented in the logbook. So we will see this example once. So logbook, for example, a student has visited to medicine ward to see any adverse drug reactions. This we will document in a logbook. What and all happened clearly. So what the patient developed, how the rash developed, how he was referred to a dermatologist, and what happened. So the detailed thing is called portfolio, and there will be a reflection also in a portfolio. So history taking during clinical postings in psychiatry. So this will be recorded in a logbook. Whereas in portfolio, exactly what all the things about the patient. For example, if a depressed patient, he is talking about what happened and exactly what throughout the procedure what they have done. That is called as a portfolio. So this is a basic difference between a logbook and portfolio. Coming to e-logbook and e-portfolio, it is nothing but digitalization which has been taken place because of easy documentation, and you can able to add upon the things easily when compared to previous normal records. So this is called e-logbook and e-portfolio. So now coming to terminologies which you commonly use. So activity. So this is referred to predetermined task performed by learner to achieve the competency is called activity. So now the differences between logbook and portfolio and similarities. So logbook will provide the evidence of having been through a learning experience, and what actually has been learned will be seen in portfolio. So logbook enlists what all learning activities has been happened, and here it describes how the learning has happened. That will be described in the portfolio. So here in logbook, it records the task done leading to competency development, whereas here it has a student reflections about the tasks which they have been achieved. Coming to similarities, both will serve as a purpose of regard and formative assessment. So competency, this definition already we have seen. So remedial, so it is a planned activity which aimed at correcting the deficits for a learner to achieve a particular competency. That is called remedial teaching or remedial classes. Feedback, it is an active intervention which is performed at the end of the assessment so that he can gain the positive change, growth and improvement of learner through guided reflection of a activity. So these are all the common terms which we commonly use in the logbook. So this is about basic definitions and terminologies which you should know in the logbook. So this is the basic structure of the logbook. So here the competency number we can address and name of the activity. So here what are all the activities which we will do to perform the competency or to achieve the competency. I will show it with an example. So this is the date, attempt at activity, whether they are doing it first time or any repeat is required or remedial is required. So first attempt, if the student has achieved, you can keep it as F. Or if he is not able to achieve that competency, you need to ask him to repeat. If two unsuccessful repeats he cannot able to do, then you should go for a remedial teaching, where a remedial or a tutorial or a specific one-to-one interaction or video lectures or whatever is available, you can able to make a student to achieve the competency. That is called a remedial. Then numerical score can be given, for example like internal assessment, or you can rate it like below expectancy, he meets the expectancy, or more than expectancy, or more satisfactory you can do. Then decision of preceptor. So preceptor can decide whether he has completed or he really requires a repeat or he requires a remedial. Then initial of the preceptor, and finally the feedback should be given, and then the initial of the student should be taken. So this is the basic role according to the NMC the logbook should have. Next, coming to choosing competencies. We cannot put all the competencies in the curriculum which they have given into a logbook, and it will be a burden even for the students and also the faculty to frequently check the logbook. So the lower level of the Miller's pyramid, as we all know, knows how, can be limited, and if at all is really necessary, we need to document. Otherwise, we need to concentrate only on above. So shows how and does components, mainly you can concentrate for the competencies. And when you are going to select any competency, core competencies can be selected, and higher level of Miller's pyramid competencies can be selected. Certifiable competencies should be definitely recorded in the logbook. So likewise, you can have the more amount of higher level of Miller's pyramid we can document in the logbook. So that is a basic thing which is shown here. So attempt at activity I already mentioned. So what is the importance? So if he is not able to perform, so example slow learner can be assessed during that time, and we can able to address him to improve his performance, and giving the rating. So if you are rating, our work will be cut down, and what are the things we need to address to the students can be improvised. And finally, decision of faculty. So if he is completed, then you can able to certify him, or if he needs repeat or remedial activity. So this will have the assessment, will drive the learning of the student. So these three parameters in the logbook carries significance in these ways. Now what is the role of logbook? So logbook is useful not only for learning but also for assessment. So what type of assessment we can do? So for example, formative assessment, that is assessment for learning, and summative assessment is, as we all know, it is assessment of learning. So assessment for learning, for example, if you talk about, it helps the student to achieve the competency, or you can guide him if he is not able to achieve the competency. Then assessment of learning, you can able to certify him that whether he has achieved the competency properly or not. So this is assessment for learning and assessment of learning. So logbook is useful for both assessment and also for learning. So this is the basic things about logbook. So this is the normal pattern. So we should have college emblem, name, address, name of the student, date of beginning of the course, registration number of university, permanent address, email and mobile number are optional. And here we will have all the subjects. So here pandemic module and Atcom module. So Atcom module is there throughout all the phases. So for phase 1, phase 2, in phase 3 medical and allied branches will have, and surgical and allied branches should have. So the logbook should have a reflections throughout all the phases in Atcom module. And pandemic module also we need to add in a logbook. So it is a comprehensive coverage, and alignment also should be there. So internship also should have, during compulsory rotatory internship, we should have a logbook, and certain changes they have been made. So they have added all these broad specialities, lab diagnosis, which was not there, Indian system of medicine, and certifiable skills they have added, and community medicine posting they have changed to 12 weeks, which was there previously for 2 months, and medicine they have decreased it to 6 weeks. So these are the changes which they have made. So logbook, whether it is again it is going to become a practical record book, or it is something different which you need to again think about it. So how much a logbook should have? So already we know that we need to choose the higher level of Miller pyramid competencies, and not all the competencies we need to be focused. So it is a burden or a role, purpose, or it is becoming another practical record book. So in practical record book we mainly talk about the cases which they have discussed in detail, but not the other components. But here, what are all the activities which they have done, we need to record in the logbook. So it is not going to become another practical record book, and it is not a burden. If you focus on the specific competencies, it will not be a burden for faculty nor a student. So this is one of the example which they have taken from ophthalmology. So demonstrate the correct technique to examine the extraocular movements of the muscles, uniocular and binocular. So this is the competency. Likewise, medicine, surgery, gynec, pediatrics and ENT, major undergraduate subjects, I have given the competencies as a group activity. So I will explain how we are going to log in our book. So for example, if you take this competency, you can have a short group discussion of what are all the ocular muscles we have, extraocular muscles, their origin, insertion. And second thing, you can demonstrate in the form of a video lecture to the student, and then you can even show in the form of a standardized patient, or you can finally show in the normal patient and ask the learner to document. So these are all the activities which you are going to perform. So in that, which I am mentioning, theoretical knowledge, short group teaching, we can eliminate from the logbook, and remaining activities you can able to document in the logbook. So that is in the activity column. So in the activity column, so you can put the competency number, name of the activity, and the date you can able to put. And attempt at activity, if they are doing at first time, you can mention it first time. Repeat or remedial if it is required, you can able to label that also here. Then numerical score can be given, or rating can be given, like below or meets expectancy, or it will exceed the expectations. Then if he is not able to perform, then remedial teaching is actually required, and then again we need to document whether he has performed it or not, and then initial and finally the feedback. So likewise, you can able to formulate the logbook for each competency. And here certifiable competencies. So minimum number is required 5. They are already mentioned in our curriculum book. So how many number is required to certify a competency? For example, here it is 5 attempts are required. So 5 different times the student needs to perform here, and then you can certify that he has achieved the competency. So that also you can able to see in the curriculum book, and you can plan it when you are framing a logbook. So this is the basic structure. Based on that, we can plan our logbooks, and the group activity is the same thing which I have mentioned over there. So you need to go in a stepwise pattern, and step by step you can able to increase the frequency of using the logbook. So these are all certain certifiable skills which definitely needs to be documented. So this is the group activity. So red group I have selected general medicine, blue group I have taken gynecology, green group I have taken ENT, yellow group I have taken pediatrics, and pink group I have taken surgery. So you can please formulate a logbook according to this, and you can post in the email. Along with that, each group I have asked what are the advantages of the students in maintaining logbook, advantages for the faculty, and advantages for the institute, and what are the challenges in maintaining the logbook, and finally what are all the newer methods which can be implemented for using the logbook. So if you read about all these things, we can still improvise, we can know what is the importance of logbook. So practically speaking, the logbook we never check regularly, and even the students won't take much responsibility to come and show to the faculty. So this is the main thing which we need to emphasize. If you frequently supervise the logbook, what are the deficits you can able to identify, and you can able to give a proper intervention for the student at that point of time, so that it will be rectified, and it will be even beneficial for the faculty also. For example, certain students cannot able to achieve the competency despite giving so many repeat attempts or remedial attempts. Then you should think about whether we need to change any competency, or whether there is a gap existing in the competency, or we can able to think, and so that the next time when you frame the competency, you can able to adjust it. So likewise, it is even helpful for the faculty also to frame the competency. So then reflection writing. So this is one of the important thing, so which we need to understand. So what happened, so what, and what next. So what happened means what happened, or how he has learnt during the process. So what and all he has learnt, what did he observe in the college, in the faculty. So all these things he need to write. So with this knowledge, what he is going to do, that is so what. And finally, what next. So if he is really in that situation, can he think any different from the situations which they have been taught, and if he is going in a different way, what are all the consequences which he is going to face. So this is called what next. So if you see the reflections, these three things are very important, and once you complete the reflections, you can give the gradings like excellent, good, average, below average, and poor. And here again, one important thing is superficial reflection and deep reflection. So what happened, so what next. If you see this inverted triangle, so what happened, superficial reflection, it won't have much importance, because this is a basic thing which everyone will observe. But as you go down here, the importance has been decreased to what next. But here in the normal triangle, if you see, what next has given the much more importance. So what they are going to do with these activities, how they are going to implement what they have learned, definitely carries much more importance. So we should always ask to practice so what and what next to be done in detail. And again, students normally when they came to elective postings also, they are asking, so daily you should write or when you should write. It is not daily the reflection they need to write. After a few sessions of observation, then they can write the reflections, so that we can read the reflections and we can really understand what the student has learned, and then we can plan accordingly the deficits which we are having. So this type of reflection carries much more importance. And self-directed learning. Similarly, self-directed learning also, after 5 to 6 self-directed learnings, then you can document about the reflection writing, what happened well, what didn't happen well, you can able to write. So and other academic activities, any participations in the symposiums or seminars, all these things can be documented. All the components of IMG, as we know, the 7 components needs to be documented if they are doing any research or if they are doing any other activities. And feedback is definitely important when you are documenting in the logbook. So this is internal assessment. You can certify so and so the name has admitted this year and completed, and he is eligible for the examination, and signature of the principal is definitely required. This all we know already. And internal assessment, for example, during internship, once they have completed, feedback should be given, like what are the strengths, what are the areas they need to improve, and finally the faculty who is signed and the department head signature should be there, and the principal signature should be there. So this is the importance of giving the feedback during the internship. So finally, it is a record of academic or co-curricular activities, and the student, he himself is responsible for that one. And second thing is getting supervised with the faculty and getting the signature also is the equal importance given to the student, and his responsibility to bring to a faculty and get it signed in frequent duration. And every month the head of the department needs to scrutinize what is happening over there, and it is nothing but a record of performance, attendance, participation, and all record completion. And finally, once before you are going to the university examination, we need to get it certified before appearing for the exam. So this is a comprehensive coverage and role expansion. So this is about overall logbook which I wanted to tell. And certain slides are the next mainly for the postgraduates, what are the things which you need to understand. So the PG student shall be trained to reflect and record the reflections in the logbook, particularly of the critical incidents. So critical incidents like any difficult case which he has come across, or any difficult situations which they come across, or any errors which they have made. So all these difficult things definitely needs to be documented so that they can able to perform better in the future and they can remember also. So critical incidents we should not miss during the post-graduation. And the purpose of logbook is to maintain the record of one's own training, and it enables the consultants to have a direct information about the particular PG trainee, and you can intervene whenever necessary. And we should give a feedback, and through which how much he has attained, how much the progress of learning has been happened, we can able to achieve. And coming to journal club, minimum they say that 1 to 2 weeks a journal club can be conducted with the indexed journal, and they should clearly see all the methodology, criticize and analyze the journals. And monitoring, the monitoring of this logbook, they should get updated at least once in a week and get its signature from the faculty, and once in a month they need to get the signature from the guide who is responsible for the logbook. And again the same thing, so which I already mentioned, they need to have attendance, performance, participation in the sessions, and acquisition of all the competencies which they have given, we need to have in the logbook. And again, you can score it like this. These are elements, and 1, 2, 3, it is less than satisfactory, or more than satisfactory, and the comments you can able to give. So this is about the PG logbook. From one article I have taken this from pediatric departments. They have taken the logbook of postgraduates very nicely. So if you see the emblem, all the same thing. So first year, second year, third year, what they are going to do, and what is the details of the postings, how they are going to post a DRP postings, peripheral postings, everything you can document like this. Coming to index, it is very nicely moduled here. So clinical skills, like what and all they have performed, DOPS or Mini-CEX or case-based discussions is the first component. Academics, they have taken case presentations, seminar, journal clubs or mortality reviews, and then thesis reviews, and then research or publications, any publications they have done, then teaching to the undergraduates, paraclinicals, preclinicals, or any allied branches, self-directed learnings, and participation in the department activities, and attitude, ethics, communication skills, and in any other activities like CMEs they have participated, we can able to frame it like this. And this is Mini-CEX evaluation. So you can see all these things, and you can grade it as I told in the morning. So first year, second year, third year, you can keep a separate document. This is about DOPS, you can keep, case-based discussions you can keep, and the seminars, case presentations. Already we have each department, we have framed certain questions. At the end, you can, faculty who is moderating can rate it accordingly, and which you can keep it as a record keeping, and also it will improve the performance of a trainee once you give the feedback. So these are all the various formats which is our, and last important thing is reflection writing. So we should educate them to write reflections so that what are the things they are lagging, we can still able to know and we can improve themselves. And finally, a few slides on clinical record maintenance. It should be maintained at departmental level, should be monitored by the department. It also have the initial information like logbook, but detailed things regarding the discussion of each case presented, procedures done will be there. and it is posting in the various phases, detailed description of cases, and these might include long cases or procedures or whatever they have done. So these are certain formats. So case discussion, so patient details, data of discussion, presenter, and what are the learning points they have taken. So this is one format, and this is for case records. So if they are seeing any case, complaints, history, systemic examination, management, discussion, follow-up can be taken. And this is the example format for procedures which they have done. So what is the patient details, supervising teacher's name, student sign, teacher sign, and details of the procedure or skill which they have performed you can take, and assessment for all these formats you can take in this type of record. So this is clinical record maintenance, and that is logbook maintenance. So finally, to conclude, students or teachers are sensitized for the purpose of logbook and their role they need to play for its successful implementation. And the next going to step will be the portfolio when they master the reflection. And if you follow both these things, you can bring a sea change in the learning experience. And finally, the competence of Indian medical graduate can be achieved. So these are suggested readings, and thank you for cooperating.
Good evening to all of you. So this is the last topic of today's program on CISP, that is regarding the curricular governance. So the objectives of this topic is to identify deviations from expected implementation plans and activities, to provide motivation to the stakeholders to bring out desired implementation, to ensure uniform implementation of new UG curriculum in all the institutes. So these are the job functions of the curricular committee. So curricular governance is a process established to design, deliver, evaluate, and improve curriculum at the institution level. And who is accountable for the delivery of the curriculum at the institute level? The dean, head of the institute, all heads of the departments, faculty, so the clinical administrative setup of the institution. So it means each and every faculty member of all departments are responsible to implement this program at institute. So it is not one man's show. It is all faculty members have to implement this curriculum at all levels. The role of the head of the department is especially crucial, because the head of the department will look after the department and he will program everything at the department level. So it is his responsibility to look after the implementation of the curriculum at a department level, and all the faculty members of the department has to cooperate with the HOD to implement the curriculum. So structure for curricular governance, the dean is the chairperson and he will look after everything. Then there is a committee, curriculum committee. Then another committee, that is a medical education unit is there, and all HODs of all departments. Then curriculum committee has a phase-wise curricular subcommittee for each phase. And there are some special teams, exclusively one team for alignment and integration. So curriculum committee has a phase-wise curricular subcommittee, that is one committee for phase 1, one committee for phase 2, and one committee for phase 3 part 1 and another committee for phase 3 part 2, and exclusively one team for alignment and integration. So these teams will look after the implementation of curriculum at 4 phases. And medical education unit will also participate in the implementation of this curriculum, and all HODs are responsible to implement this curriculum at all levels. And overall supervision will be by the dean. So the curriculum committee ensures that the institutional curricular plan and its delivery, they are aligned to and in accordance to the principles and requirements enshrined in the GMAR document, that is a Graduate Medical Education Regulations document. So who are the members of the curriculum committee? So the dean is the chairperson of the committee. One professor or associate from medicine and allied departments. One professor or associate professor from surgical group. One professor or associate professor from paraclinical discipline, that is pharmacology, pathology, micro and community medicine and forensic medicine. One professor or associate professor from preclinical discipline, that is anatomy, physiology and biochemistry. So 4 persons, and these are the 2 latest additions. One assistant professor with a minimum 5 years of teaching experience. So one assistant professor with a minimum 5 years of teaching experience means he will be an associate professor. From medical group, one assistant professor with a minimum 5 years of teaching experience from surgical group. These are the 2 additions, recent additions by NMC in the curriculum committee. MU coordinator of the college will be a member of the curriculum committee, and there will be one student representative from phase 3. So these are the members of the curriculum committee at college level. So one dean is the chairperson, and 4 professors and 2 assistants and one coordinator, medical education coordinator, and one student representative. So at our college level, deans are, and from medical specialties, Padma Sudhakar, that is a professor and head of the Department of Psychiatry. Surgical group, Dr. Siddharth, and from paraclinical discipline, myself, and a preclinical discipline, anatomy professor, Dr. Padmavati, madam, and among medical group assistant professor level, Dr. Dinesh, and at surgical, Dr. Lokesh, MA coordinator of our associate dean, Madam Dr. Ramya Ramakrishnan. These are the members of the curriculum committee of Apollo Institute of Medical Sciences and Research. So role of department head. So head of the department is responsible for curriculum implementation in the department. So ultimate responsibility is the head of the department. All faculty members have to cooperate with the HOD to implement a curriculum at all levels. To identify training needs for faculty in the department. To ensure smooth delivery of the curriculum in liaison with other HODs, because there is alignment and integration, so that HOD has to cooperate with other HODs to implement alignment and integration part of the curriculum. To take the responsibility to implement aligned and integrated topics, and to support faculty and students in implementing the curriculum. These are the role, job functions of the head of the department to implement curriculum at department level. Who is responsible for the oversight of the curriculum? And the curriculum committee is responsible for the oversight of the curriculum. Curriculum committee is responsible for the oversight of the curriculum. The curriculum committee ensures that the institutional curricular plan and its delivery, they are aligned to and in accordance to the principles and requirements enshrined in the GMR document. So curriculum committee is responsible for the oversight of the curriculum at institute level. So activities of the curriculum committee: overall in charge of the curricular delivery, meets at least 4 times in a year, and the curriculum committee provides oversight and support of the curricular program, and the curriculum committee creates the timetable with the help of the phase-wise curriculum subcommittees and alignment and integration committee, and approves them. So this is one of the important job functions of the curriculum committee, to approve the timetable of each phase. and provides the necessary authority and support for the work of the curriculum, and responsible for preparation of reports and reporting as required by the NMC. We have to submit a quarterly report to our nodal center of all the activities that were done by all the departments. Each and every quarter, our associate dean will send the report by collecting the information from all HODs. So curriculum committee has subcommittees. One is called as phase-wise curriculum subcommittee. That is, for each phase there will be one subcommittee, and that subcommittee consists of 3 HODs of those departments or one of the key faculty member from each department, and with representation from members of other phases, and this committee reports to the curriculum committee. So curriculum committee has 4 subcommittees, and each subcommittee has the heads of the departments of that particular phase, either the head of the department or one of the key faculty member from the department may be there in the phase-wise curriculum subcommittee. So what are the job functions of the curriculum subcommittee? This curriculum subcommittee is responsible for implementation of curriculum in each phase. This subcommittee is responsible for implementation of curriculum in each phase, meets as often as needed, and this subcommittee reviews competencies for each phase, converts them into learning objectives, and this subcommittee works in aligning curriculum as much as possible and enlisting help from other phases in creating necessary vertical integration and links. So alignment and integration is one of the important components of the curriculum, and this job has to be done by the phase-wise curriculum subcommittee. Reduces redundancy across the phase by integrating overlapping teaching elements, and develops learning and assessment methods for each phase, and prepares timetable for phase and presents it to curriculum committee for approval, and collects feedback and provides student support. So these are the job functions of the phase-wise curricular subcommittee. So this subcommittee consists of heads of the departments of that particular phase, or any one of the key faculty members of that particular departments. So there is another team which works under the curriculum committee that is named as Alignment and Integration Team. Alignment and Integration Team, AIT, and a group of faculty that will ensure that a aligned and integrated topic is delivered. Each team will have at least one member from each department. So nearly 20 departments we have 20 departments. One from each department will be there in this alignment and integration team, and is responsible for delivery of the topics. This team reports to the curricular committee. So what are the job functions of the alignment and integration team? It creates modules or sessions of the alignment and integration identified across phases. Each team will have team with representation from subjects involved in topic. A team leader from each AIT represents AIT to subcommittee and or curriculum committee. Reviews competencies and develops learning objectives for topic. Assigns learning objectives to each phase and teaching lesson session. Develops learning and assessment methods for the alignment and integration. Helps faculty delivering session in collaborative manner across phases. Collects feedback for this program and provides student support. So there is an exclusively one committee to look after alignment and integration, about the implementation of this alignment and integration in various phases. And who will support, enable and facilitate faculty to deliver curriculum is the medical education unit. It provides a faculty education and support, capacity development. And the medical education unit helps develop teaching and assessment methods and training faculty for each. May be involved in program evaluation and quality improvement of the curriculum. And it lies with the regional and nodal centers of nodal center. Our nodal center is the CMC Vellore. And universities will also have a role in implementing the curriculum at institute level. So who should do monitoring and how frequently is self-monitoring is the best method? Second, monitoring by institutional medical education unit on monthly basis, monitoring of impact on students, faculty by institutions, quarterly meeting of curriculum committee in the colleges every year, and a report to be submitted to the nodal center or regional center within a month of the meeting. So this is, now we are doing this job. Monitoring of institutional medical education by regional or nodal centers quarterly. Nodal center will also monitor us. Then institutional monitoring during college inspections by National Medical Commission. So this institute, NMC, nodal center, they will monitor this curriculum implementation at the institute level. So curriculum, who does what? So responsible oversight. Timetable is the responsibility of the curriculum committee and phase-wise curriculum subcommittees. Oversight is the principal or dean, he is the chairperson of the curriculum committee. Selection of topics for alignment and integration will be looked after by the curriculum committee. Development of topic-based learning objectives, it is a phase-wise subcommittee and oversight is curriculum committee. Lesson plan based on objectives, department concerned. And faculty development, medical education unit. And program evaluation and quality, institution quality unit, or if not present, medical education unit will take care of this. So this is the suggested reading recommended by the National Medical Commission, and we profusely thank the NMC Executive Committee on Faculty Development Program of the National Medical Commission for implementation of this program. Thank you very much. And so my request is that all faculty members have to take an active part in implementing this curriculum at your level. Thank you.
Yes. So we have come to the end of the sessions, but before leaving the hall, little small things to wind up. One is regarding a repertoire session by Dr. Ashish, and post-test, feedback, and then a small valedictory. Then we'll finish and then go. Another 15 minutes probably. I just asked Dr. Ashish to come forward to give his today's repertoire report. You have? Can you just mail to that so that he can get? Yeah. Meanwhile, the feedback are you sending? Post-test also. Post-test? No, he is ready actually. He wants to send the mail. So before that, I asked the participants, we are of 5 groups. So voluntarily, I ask any one of the participants to come forward to give a feedback regarding the sessions happened in this CISP 3. Email ID Vetamma. Vijay. Email ID Vetamma, sir. One faculty participant to come forward, or otherwise from each group 1. Yeah. Now this is a part. This is a part of what you call just a feedback of this 2-day session, how it went. I think Dr. Ashish is coming for the repertoire. Yeah, okay. I'll start with group red. Who is coming? Dr. Srikanth? Dr. Kavya? Yeah, please, nothing. Just 2 days feedback, that's all.
I'll do it after that. Good evening, everyone. Yesterday and today, overall, I've learned how to improve my talent in making the timetable and overall scheduling of the curriculum, including implementing the CBME in our routine curriculum and how to make these specific learning objectives from each of the competencies, and what are different teaching learning methods that I can use along with the assessment methods. And overall, I feel that I've definitely can implement in this in my department. Thank you.
I think we can add in such a way. So in the logbook, reflections, how the reflections have come. So what happened, so what, and what next. So these things will help you out to come forward to tell the feedback how it is going on. I asked you are ready? Yes. Yeah. The repetitive report will be there.
Of today's summary. I'm Dr. Ashish from the Department of Orthopedics. So, today morning we had a session regarding doctor and student relationship by Dr. Sridhar sir. So, he told us to share some of our experiences during our undergraduate days, what motivated us to become a doctor. And he also told about what the relationship should get into a student, like his communication skills, skill development under supervision. There should be structured clinical teachings from basics to advanced level. There should be constant assessments so that you can give the feedback to the students and they'll know how to change, how to develop skills. Then we had a session on skill development by Dr. Lokesh, Dr. Siddharth and Dr. Ramya ma'am. So we saw what are the different kinds of skills: intellectual, psychomotor, communication and team skills. So all these skills are predefined for various phases in our curriculum from first year to final year. Their steps are clearly outlined. Then we got to know about criticality and feasibility of the skills and the four domains that are there depending on high and low feasibility and criticality. Then we had a couple of group activities. So the first group activity was I think Ramya ma'am has given us a skill and we had to put it into one of those four domains. The second group activity was we were given a domain and we had to put all the skills that were there in the particular domain. Then we had another group activity, 1 minute perceptor model for teaching intellectual skill. Then we had another development of psychomotor skill. It is done by Python's 4-step approach, that is demonstrate, deconstruct, comprehension and performance. Then teaching of technical skill by steps module and communication by Kalamazoo's declaration. Later we had, before the lunch, we had one skill sessions plan. So this was also pre-lunch session, assessment in CBME. We all know the kind of assessments we have: summative, formative, internal assessments. Then the Miller's pyramid, know, knows how, shows how and does. So there are various forms of assessment for each of these methods. And Dr. Dinesh showed us about evaluation through Mini-CEX, where we had a role play by a psychiatry resident and 2 interns, which was very good. Then we had a break for lunch. We had a good lunch, following which we started our assessment, another assessment group activity, that is our OSI and OSPE station. So all of us were assigned different roles. So now we know how to conduct OSI, OSPE station or exam. Then we got to know about drafting schedules. Dr. Sarvana ma'am has taken the class. Did I get it wrong? Okay, so all the teaching hours are already allotted for all the subject-wise teaching hours are allotted, and we had a group activity on how to put down a schedule. So our group had regarding clinical postings for final year. Then we had a logbook record and the importance of logbook. Why do we have to have a logbook? It is both for assessing continuous assessment of the student and to see how much he has learned, and the difference between logbook and portfolio. Our last session by Dr. Kailasnath Reddy sir was regarding curriculum governance and the curriculum committee that has been formed in the institution, and how the medical education unit trains all the people for implementation of curriculum and the staff needed. That's it for today. Thank you.
Very crisply and elaborative, both are there. Thank you, Dr. Ashish. And yeah.
So we have shared the Google Forms of post-test and the day 2 feedback in the WhatsApp group. Also we are circulating you a retro pre-form where you have to write your score between 0 to 5 before the session, like before the CISP and after the CISP for each session. What is your understanding of your knowledge and importance of that topic? Before CISP and after CISP, please rate your knowledge and importance on that topic. Also, please give your suggestions, any feedback, please mention in that form also along with the Google form circulated.
Hello, check.
So meanwhile, any other faculty wants to give your feedback from any other group? Thank you so much.
Two minutes. Okay. Madam? Okay. Good evening, everyone. This is Dr. Pawan. Before attending the CISP program, I was like, only for the promotion thing, I am going to attend this one. That is my agenda, actually. But when I came to the CISP program, ma'am has permitted me to attend as an waiting list candidate. So I thank ma'am and Ramya ma'am for this thing. And basically most of, I'm a clinical guy. For me it is, I have no UG students for me, no PGs also. So I was like, okay, for promotion we'll go ahead. But however, I have learned many things in this CISP program about the CBME curriculum and regarding the electives, group discussions, and we had good OSPEs and OSCEs also. So I think it is more helpful for people like me also. When we are getting PG seats, it will be more helpful, and further to structure the programs like electives and all. So I think I'm thankful to this program. Thanks.
I request any of the faculty member to come forward to give a feedback of this today's session. Dr. Ramya, please. Oh, one more participant. Good.
How exactly I would say my position right now is, after a 4th year MBBS student completes or he gets an internship, he feels that I'm a doctor now. Like that after this is, I want to implement all these teaching programs and feel as a real teacher. That's what it has inspired me. Like after you learn everything and you put it and on the patient care. Similarly, what I have learned, I want to experiment and see how it is like on the students and how is it going to be beneficial.
Dr. Ramya, please.
One person should submit the post-test date, so please submit it time.
I feel the two-day workshop was, first of all, very well organized. Thanks to our Associate Dean, Dr. Ramya ma'am. She spearheaded the whole thing. She has helped all the resource persons. I would like to thank our observer. Ma'am, with your, you were very patient, very cooperative. Thank you so much for being with us. I think all the sessions were well organized. The topics selected were very good. The resource persons were all specialists in their field, and I think they did a very good job under the guidance. And I'm very happy for the venue. I think it kept us all very cool from the scorching heat. Overall, a big thanks to all the participants for your enthusiastic participation. Without your cooperation, I don't think it would have been successful. We are so happy all of you were here on time. You assembled back on time. On day one, the lunch was stretched. I mean, it was a little late, but then there was full support from your side. So thank you very much.
Thank you, Dr. Ramya ma'am. So we'll go to the valedictory. I just ask our NMC observer madam, Dr. Blessisara madam, to come forward, and Dr. Kailash Chandra Reddy sir, so to give the memento to madam, please. Board, yeah. Thank you, sir. Madam, please, no, before the certificate, we just want your feedback and your this thing for the this two-day program.
Thank you for this time. I think the 2 days was well organized, and it was great to be part of this CISP program in Apollo Hospital. I'm really very impressed with the whole medical education department here. I think everything is very systematically planned. I think all credits go to Ramya ma'am. She's such a dynamic lady, and you know, whenever I see her, I am reminded of my teachers. I feel like standing up and wishing her. So it's so nice. It's great workshop. Maybe something which we can improve is on our time management. Probably we should be having some time alarm or something so that people do not exceed the time which they have to. And most of the participants have really participated well. Some are very enthusiastic, some are quieter, but the faculty who were there made sure everybody took part. That is very good. And overall, I think it's a great workshop. The venue, everything is going on very well. All the best for future workshops too.
Thank you for such a good words, madam. Thank you very much. And yeah, please. I ask our MU coordinator, madam, to come forward. Probably everyone will be waiting for the certificates. You need to tell something regarding it. Yeah.
Thank you, Dr. Kishore. Thank you, Dr. Sarah, for those kind words. We truly appreciate your patience, cooperation, and your inputs to our program, and we'll make note of your suggestions. First of all, again, I would like to thank all the participants. You know, you're from different departments, different faces, but yet you gel well in your group very well, and the group activities went on very well, and I think that is what we want. Ultimately, all these big plans and curriculum and everything, after all, the end user is the faculty and the students. So if that message goes across and the understanding is there among you, then that is, I would say that our purpose of this program is already achieved, because as I am waiting for the valedictory, I can see everybody putting the group activity or already finished the logbook activity or posted it. I think that is the kind of motivation that I am very happy to see in our faculty, and again, very blessed to be with all of you here. And of course, we have an excellent team in both MU and CC. We have senior members, Kailasnath Reddy sir, Padma Sudhakar, Sridhar sir, Shubhadra ma'am, and all these active youngsters with me. So, you know, they are a real workforce, and you just have to message them, call them, in the next 5 minutes they are there with you to plan whatever has to be planned, despite everybody's busy schedule. And you know, some of the departments are really stretched for teaching and hours, but still they are willing to spend the extra hour to plan all this so that everybody benefits. I think this is the kind of teamwork that we should be doing ahead also. So thank you once again, and I should thank the Vice Chancellor of the Apollo University, who suggested that we start using this venue for all our FDPs. And so we kind of, with trepidation, try to move all the furniture initially from our MU into this, and I got permission from the Nodal Center that it will be in a slightly different venue. Is it okay? So they said, go right ahead, as long as you're able to give all the elements of the program in this hall. They were given, I was given permission, so with that we shifted in. I'm happy with the review about the venue. Of course, some things have to be tweaked, we'll do that. So again, thank the management, the Dean, the COO for making all this possible. We thank the wonderful IT team, our ever enthusiastic photographer and his team, the housekeeping, the hall in charge, and of course, I have to thank my secretary, Mrs. Rekha. She is one bright, cheerful person. She talks in Telugu to me, I talk to her in Tamil, and somehow we get along with each other. The work is done. So we have these kind of support, and of course, Dean Secretary, Mrs. Supriya, also has contributed to this. So I thank once again all of you for your very active participation, and hopefully, you know, so many of you have given me feedback over coffee and lunch yesterday and today. Definitely, I will keep that in mind, and whatever suggestions you're giving, we are going to put it in place so that it's much easier for you to actually do the groundwork with the students. And thank you very much for all your suggestions. And very happy learning we had, and hope to learn along with all of you. Thank you very much. Thank you.
Just tell them that.
I know you're all waiting to get your certificates, but unfortunately, for some reason, we couldn't get the dean's signature. He had to, you know, go on an emergency home. So as soon as he's back, I will get the certificate signed, and then Mrs. Supriya in the dean's office will inform each one of you. Personally, you have to come and collect the certificate. I'm not going to send it to any department or anything, because it's a precious certificate. I don't want it to be lost on the way. Dr. Sarah has kindly signed the certificate despite the fact the dean's signature is not there. I should thank ma'am for that. So once dean signs, I will inform Supriya to call each one of you. When you have the time, please come and collect the certificate from the dean's office. Thank you very much again.
No, national anthem is there. Please, all of you stand so that you can.
Janagana mana adhinayaka jaya he Bharata bhagya vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय जय हे।
Okay, thank you. Can disperse.